started.
Last week it was confusing because there's so much information. This is what we're going to do today.
All right. Kim, are you ready?
Yeah. Woo! Go Callaway. I'm so excited for that. I'm a little personal trivia. I love it.
Okay. So, Kim.
Yes, ma'am.
There it is. Okay. I was like, what happened? I think that's going to show you on the screen.
Okay.
Just let me know when you're ready to go to the next slide. We'll make that happen.
Okay. Alrighty, I did echinacea. That's how I say it. So what is echinacea? It's a plant in the daisy family. It looks a lot like a daisy. It's also called the purple cone flower due to its color and shape. It's actually a worldwide known herb. It's pretty popular, and it was used by Native Americans for centuries to treat many things. It's found in North America, and it grows in wooded areas and prairies. And it has 9 species, but only 3 of them are actually used for herbal supplements. Just 3. Next slide. What is it for? So it's an over-the-counter herbal remedy for rhinovirus and flu. It's also used to treat pain, inflammation, migraines. Some studies have shown that it can lower blood sugar and improve your immune system. It can be an antioxidant, helps with cancer like everything else. It can be potential aid in anxiety as well. And then since it has an anti-inflammatory and antibacterial property, it can help treat acne by suppressing this propion bacterium, which is like a main cause of acne. Next slide. All right, so which part and why? So it's actually going to be like the top part of the flower. It's used in tablets, tinctures, extracts, and teas. It contains compounds that function as antioxidants. So the flavonoids, I can't pronounce this one, sicoric acid, and rosmarinic acid. So it helps defend your body against oxidative stress, which can lead to diabetes and heart disease. And so the flower portion of it is actually what's going to contain most of the antioxidants. All right, so this is blood sugar effects. I don't really know how accurate this is. It did say that it's still lacking, but it suppresses enzymes that digest carbohydrates, so it reduces the amount of sugar that's actually entering the bloodstream. Other studies have shown that it makes cells more sensitive to insulin, and it activates this PPAR-Y receptor, which is a common receptor for diabetic drugs. It works on removing excess fat from the blood, which is a possible insulin resistance issue. That makes it easier for cells to be able to respond to insulin. But again, this is still lacking in some research. Anti-inflammatory. So there was a 30-day study with some adults that had osteoarthritis, and they were taking echinacea. It showed that they reduced in inflammation, chronic pain, and swelling more significantly than NSAIDs. Some side effects. So echinacea has been considered to be safe for a short period of time. However, some of the side effects are like rashes, itchiness, hives, swelling, nausea, pain. So most of that is because they're allergic to the flower, not necessarily the extract itself. So if you're allergic to daisies or chrysanthemums or marigolds, don't take it. Next slide. So contraindications: do not take, or you can ask your doctor if you have an autoimmune disease, if you're taking immunosuppressant drugs, and also if you're allergic to flowers like the daisy, marigold, chrysanthemums. You want to watch it with the autoimmune and the immune suppressant because it does boost your immune system. So kind of like how garlic was, if it's already induced, you don't want to boost it more. Next slide. All right, so there actually isn't an official dosage for this, but they do say that these following doses can be a little bit effective in helping with your immunity. So dry powder extract, 300 to 500 milligrams 3 times a day. The liquid extract is 2.5 milliliters 3 times a day, or up to 10 milliliters a day. So when you're taking this, not all products actually contain echinacea. So make sure you're reading the label and seeing that it actually contains it, and buy from brands that you trust. So these are for short term. Long term, they actually don't have any known effects. So it's not recommended to take for a long time. All right, so my learning activity, I have a select all that applies question. Echinacea is a remedy for inflammation, acne, thrombocytopenia, oxidative stress, and making cells less reactive to insulin. What do you guys think?
Acne. Making cells less reactive.
Less reactive to carb. Well, they don't absorb the first.
Yes. It's inflammation, acne, and oxidative stress. Next
It's an
slide.
antioxidant.
Yeah.
And it makes cells more reactive to insulin.
And another one. So which patient would it be a contraindication for them to take echinacea extract? A patient who is allergic to dust, a patient with swelling in their joints, a patient that has an autoimmune disease or is taking immunosuppressant drugs, a patient who is experiencing symptoms associated with rhinovirus. You guys are right. That's my Thanks.
Oh, yeah.
Hey,
Woo woo. Okay.
dog did well. They took that dog last night.
Oh.
My backyard.
Hannah says that it helps mono too.
That makes sense. It's also like an antiviral.
Yeah, an antiviral type stuff. Yeah, just kind of boosts your immunity. Fantastic. Okay.
She's humble.
Debbie, they're wondering for what? Oh, for URI. So yeah, so for colds, flus. Drink it in a tea. Does it come in teas, Kim? I'm sure it does. I think you can get it like, you remember, I don't know if you guys do remember, they're like Jamba Juice and smoothies. They were really big at one time. And so they would always put like additives in it, like echinacea or ginkgo biloba or something like that. And you could like pick which little additive you wanted in your smoothie. And I'm sure they still do it, but it's like Jamba Juice and stuff like that isn't quite as big as it used to be. Not quite as popular. Okay. All right, let's see. Guess what we're going to learn about today? Amy got it. Drugs. Surprise. Just kidding. Okay. We are going to learn about antibiotics. Yay. We're going to go a little bit. We're not going to deal with the heart anymore. Well, at least for now. Okay. Antibiotics. All right. I got treats here. For all you guys online, you're missing out, my friends. Missing out. I got vanilla Tootsie Rolls and a big fat bag of High Chews. Missing out on the sugar. Okay, so talking about anti-infective pharmacotherapy. So what do you guys know about antibiotics? The whole course. Amy, I'm going to hit you. I'm going to try to throw these to you. Oh. Second time's the charm, right? She got two because of my poor throwing skills. What else do you know about antibiotics? Woo! Nothing for viruses. Fight bacteria. What else? Oh, guys, I don't know if I can throw that far. Let's see. Ashley. Okay, we'll split those up. The plexiglass is screwing things up for me. What else? What else do you know about antibiotics? Yep. A lot of different routes. You can get seed. Oh, I knew that was short. There we go. And that was long. Okay. You can get C. diff potentially. We'll talk about that.
Ooh, MRSA.
Marin.
How long you have to give over, like 10 minutes when you're IV?
Or Mark, sorry. Oh, Marin. This plexiglass is bad. What? What was that? Oh, no.
You don't have that.
What? Please tell me you know that.
You'll develop a tolerance to it.
Yeah, the MRSA.
Did you get yours, Emma?
Did you get yours? Okay, well, let me know.
My throwing must be getting good or bad because you guys are flinching now every time I throw it. Okay. Anything else we know about antibiotics? Take probiotics with them. Ooh, that was a good one. Yes. Okay, let's see. Woo! I'm getting better. Getting better, getting better. Okay, so you guys already know a lot. We're going to learn more. Okay. There's our learning objectives. Okay. So let's talk about pathogens. Pathogens cause disease. Are we done talking about the Dodgers? Mark's all decked out in his Dodgers stuff.
He was here.
Are you going to clean it every day? Don't they have 7 games?
I don't even before.
They're only gonna, oh, yes. That's right. There's only going to be 4 games.
No. Nitro.
Hell yeah.
Okay. Pathogens. Pathogens cause disease due to their ability to invade tissues or secrete toxins. Okay. Microorganisms that are capable of causing human disease. We have a whole bunch. They're all listed there for you. Viruses, bacteria, fungi, or fungi, however you want to say it. Unicellular organisms like protozoans, multicellular animals like fleas, mites, worms.
I'll take you, please.
Okay, so there's going to be a lot of words and definitions that you just need to know and understand, okay? Kim, you got such a pile of garbage up there. Okay. Let's see. So pathogenicity, the ability of an organism to cause disease. Okay, it depends on the speed of reproduction, the skill in bypassing or overcoming body defenses, among other things. And then we have opportunistic pathogens, which are organisms that usually infect only when the body's immune system is suppressed. So, do we do high chews this time? They're bigger. Okay, tell me an opportunistic pathogen. Okay, tell me C. diff.
Yeah.
Mark, I thought you'd get that one.
Right.
So it's an organism that usually infects only when the body's immune system is suppressed. So that's probably the biggest one is the E. coli.
What about like ringworm?
Ringworm? What's another one? There's another big one that's like on your skin all the time. Salmonella will make you sick regardless. What was that? MRSA. You can't get MRSA. Staph. That's the one I was looking for.
What about UTI?
Victoria, I'll give you MRSA. Well, I'll give it to Mark, and then he can give it to you. Okay, so we have a lot of these things. E. coli is in everybody. Everybody has E. coli. However, it can cause UTIs. It can cause C. diff if everything's just right? Okay, so we got to figure out how to describe and classify bacteria. We'll just go through this quick. Who took microbiology? Do you have to take microbiology?
I think we're bachelors. I'm not sure.
Okay, but
I took
Jared took it. You took it.
Yeah, I took it.
Mark took it. Some of you guys took microbiology, so this will be. They covered this in microbiology too. So a review for some of you. So bacteria are described by their shape. So we have the cocci, which are cyclical. Is that right? Cyclical? Spherical? They're circles. Okay. Woo! We have bacilli, which are like rod shaped. And then we have all these other ones that are fun. Okay. So, and then we talk about gram staining. Who's heard of gram staining? Everybody, right? You're going to get a call as a nurse, and they're going to say, hey, this is the lab. We've got a gram-positive staphylococci. What does that mean? What?
They have staff.
Right. So, who knows why it's important to know if it's gram-positive or gram-negative? Okay, Mark, what were you going to say?
I was gonna say the same thing as Amy.
Same thing as Amy.
I was just gonna say like there's different types of antibiotics that treat different like the cell membranes or the cell walls when it has or something like that.
Correct. Yes. Yeah. So some antibiotics will do really well with gram positive. Some antibiotics do really well with gram negative. Okay. So here's kind of the difference. We've got this gram negative that has this outer membrane. This is the stuff that dies, right? Gram positive doesn't really have an outer membrane. These are just some gram positive organisms and gram negative organisms. I will not test you on which one is gram positive and which one is gram negative. Okay? As a nurse, you guys don't necessarily need to know that. The lab will tell you what organism you have. Okay? But just know, they've got gram positive, gram negative. It's important to kind of know those things, right? So yeah, like you guys said, it just depends on which the differences are between the two groups will determine which drug will be effective. Okay, so you guys knew that. So some are we're going to talk about broad spectrum and narrow spectrum. So it's good to know if you're gram positive. And then we have we classify them by aerobic and anaerobic, whether they use oxygen or not. And some of them go back and forth. So some can switch back and forth, and that can be a little tricky sometimes. Because some antibiotics are selective on if they're anaerobic or aerobic. Okay. All these good things to know. So they're classified by their organism, chemical structure, and mechanism of actions as far as our anti-infectives go. Oh, I was going to show you, before we jump into antibiotics, I'm going to show you this one right here. How our body fights infection first. So this right here is our body's immune system, microphage, I think. And this little guy it's chasing is your pathogen. And that's under an electron microscope. And so that is what our body does naturally, our natural defenses. Look, scoops him up, catches him. And he's done. You guys want to see that again? That was pretty awesome.
That's kind of fun to watch, I gotta say.
Right? Look, he's like honing in on him.
I was saying it back to you.
Look at that. Oh, he gets him. He's done for. He's done for. Yeah.
You know what those little other round balls were?
I'm gonna guess those are red blood cells.
Okay.
Okay. So that's what our body does, but sometimes it's just not enough, right? Our body's pretty amazing, but we need help sometimes. So we get these anti-infective drugs. So they're classified by the organisms they kill, chemical structure, and mechanism of action. Okay. More verbiage to know. Anti-infective is any medication that is effective against a pathogen. Anti-infective. Then we have antibiotics, which are chemicals produced by one microorganism that inhibits the growth or kills another microorganism. A lot of these newer drugs are produced synthetically. So we have synthetically made antibiotics. Now, antibacterial, antimicrobial, and antibiotics, they do have tiny difference in their definition, but they're going to be used interchangeably. Mark.
So you could say that an anti-infective is also an antibacterial and antimicrobial.
Yep.
And an antibiotic.
Yep.
is also considered anti-infective. Okay.
Yes. Yes. Now notice what's not on there. Antivirals. Those are a little different. Viruses are another fun ball game, which we'll cover, but not today. Okay, so antivirals are a little different, but antibacterial, antimicrobial, and antibiotic can be used interchangeably. Okay, so there's a couple different mechanism of actions. So let's see. A goal of an anti-infective is to assist the body in eliminating infection. Okay, so they can kill a bacteria, which are called bactericidal. Important to know these differences, guys. Bactericidal kill the bacteria. Bacteriostatic doesn't kill them, but it slows their growth down. Okay, it kind of halts there so they're not multiplying like crazy. So it kind of gives our body a one-up on them to fight it off, right? If you're not fighting as many people, you can, it might take a little bit of time, but you can get them all.
So with the bacteriostatic, would that be beneficial because it's not killing as much as your good bacteria, maybe? Is it going to also do the static thing with your good bacteria?
Probably, yeah. These antibiotics, they're not, exactly. Thanks, Mark. They're not selective on the bacteria.
Right.
They just kind of are like, bacteria, we don't care if you're good or bad. We're going to get you. We're going to get you. We're going to get you. But yes, you might see less side effects as far as nosocomial infections or something like that with a bacteriostatic versus bactericidal. Still going to get them, but maybe not quite as bad. Okay. We got bactericidal and bacteriostatic down. Suicidal. Is there a suistatic? I don't know. Anyway. Okay, so going a little bit deeper. So generally there's these bacteriostatics, bactericidals. So going just a little bit deeper, there are 5 major methods, like going past that a little more defined. So they can inhibit the cell wall synthesis. So now these bacteria can't make cell walls, right? They inhibit protein synthesis. They can't make their proteins, right? They disrupt plasma membranes. Right, yep. They inhibit the nucleic acid synthesis, so they can't replicate. Right? They mess up the bacteria's DNA, so they can't replicate. And inhibit the metabolic pathways. So those are more detail on how they do it. Here is a picture of a fantastic picture in a book. that goes through, and as you can see, we've got like rifampin, we've got the carbapenems, cephalosporins, fluoroquinolones, and it just kind of, there's a cell, a bacterial cell, that it kind of tells you where each one is going to act. For those who are picture learners. Required resistance. What's required resistance, and why is it a problem?
Is the ability of an organism to become unresponsive over time to the effects of an antibiotic.
Fantastic! Cam, you've got it.
There you go, Amy.
Okay, right. So we have acquired resistance with bacteria, or with antibiotics, anti-infectives, antimicrobials. Who knows who developed penicillin? Who found penicillin?
Alexander Fleming.
Woo, Mark. You got it. Alexander Fleming. You know how I found it?
Red mold.
Accidentally. He left dishes in his sink and went on a vacation and came back with those dirty dishes still in his sink, and they grew mold.
See, that's what I should do dishes every day.
Best things are accidents.
So it was actually, yes, it was completely by accident. It was found in his kitchen sink in the 1930s, I believe. And by start of World War II, which was what, 1941, right? They were using it in World War II, and it was like this miracle drug, and everybody thought that all would be healed and all these infections would go away. And so they were like, give it to everybody. And we still do that to this day, right? You go and you're like, I got a cough, and they're like, antibiotic.
Oh, yeah, and they get
Yeah. Yeah. They get home, and I'm sure you guys have all had friends and parents and family members who are like, I went to the doctor and they just said it was viral and sent me home. What are they thinking? I need an antibiotic.
Yeah.
Right? And they get mad. Anyway.
But Google says
I looked up all my symptoms. And I
Mom's page says.
I read on the worst.
Right. Okay. So, and we still do it today. And now there's this big, I'm sure you guys have all seen it. There's this big, like, program. I don't know. Anyway, this big, what am I trying to say, guys? Movement. Thank you. To stop prescribing so much antibiotics. Okay? Because a lot of the times they're not needed. A lot of times it is viral. And your body will fight that off. Given time, you will be fine.
Really, the world has bacterial and viral mixed up right now. Like, we should stop giving as much antibiotics, but still give vaccines.
Right? Yep, everybody has like vaccines, antivirals, antibacterials, like all intermixed and confused. Okay, so here's a little thing. So we have our resistant organism. We have our antibiotic. Is it doing anything for that organism? Clearly not. And so what's going to happen? Through time, they're going to replicate, and the antibiotic's no longer effective.
They pop up out of nowhere.
Yes. Okay. Let's see what else I need to tell you. Okay. So we have a couple different mechanisms of resistance, okay? We have destruction of the drug. So we have enzymes in our body that can destroy or deactivate the drug. And they can get better and better at it, okay? Or the bacteria can develop enzymes that deactivate the drug. Pretty crazy, right? Okay. Prevention of drug entry into the pathogens. So bacteria can make enzymes that can keep the drug from crossing the cell wall. How are the drugs gonna go in and mess up their DNA or mess up their protein, right? They have to cross that cell wall, cell membrane. And so if the bacteria can keep the antibiotic out, they can still reproduce. They can still do their stuff. Removal by resistance pumps. So they can develop pumps that keep the antibiotic, like if the antibiotic penetrates the bacteria can say, oh, you're out of here. Get out of here. You're not welcome here. And push it out before it reaches whatever it needs to reach to disrupt it, right? They can change the shape of receptors. So now the drug's going around like, not finding anything I need to kill because they've changed the lock, right? That's right. That's exactly right. Power Rangers. I always thought the pink one's the cutest anyway. Let's see. And then they can morph, find an alternative way to grow. Okay. Right, Power Rangers, they morph.
Totally.
Oh, that was the best.
Okay. So let's see. This guy, can you read that? It says, you are the next class of drug resistance bacteria. As humans continue to abuse and overuse antibiotics, your ranks will swell. So go out there and mutate. And remember, that which does not kill us makes us stronger.
Aw, I like that message.
Right? 2020.
Exactly the same
Is that
thing.
2020?
Oh, I think it says 2000, but it definitely could be 2020. Okay. Awesome. Let's see. So because they mutate, they can, okay, so I'm not sure if I have a slide on this. Where does this go? Okay, so this is how we prevent. So, and let's see, just in my notes, just so you guys know, bacteria can have inherent resistance, which is like a natural resistance to antibiotic through mutation or whatever it is, naturally resistant. Or they can have acquired resistance. And what do you think that one's from? Or, so taking the antibiotic too much, or what's the opposite of that? Not taking enough, right? So you take you take your 5-day dose of antibiotics or 7-day dose of antibiotics. It's really supposed to be 10 or 14 days. And you're like, I feel great. Like, I'm totally over this. I feel great. No big deal. You stop taking it or forget about it like I do, because I'm like, when I'm sick, I remember to take my medicine, right? Feel better. I don't feel like I need it. So I stopped taking it. But all the bacteria, it's at a lower level, so it's not making me sick, but it doesn't mean it's gone. So now this bacteria, which is either being killed off or being slowed down, now doesn't have really much to resist. So now it's like, oh, well, now we can start growing again. And they grow, and now I'm sick again. Right? So then I take that antibiotic again, and bacteria, they don't have brains, but they're pretty dang smart.
You're saying the resistance increases with too much antibiotic and not enough.
Yeah. Yep.
Oh, okay.
Like if you're overusing it, and it could be, like say you have, because this happens a lot, especially in the wintertime, you can get a virus, and they can give you antibiotics for it, and you can take it, and maybe you don't finish it or something, but you also have a bacterial infection. Does that make sense? You get one a little bit later on. So now
So like you're
explaining
taking
this.
antibiotics and then like you end up finishing it, but your bacterial infection started like halfway through, so you never actually killed the entire virus.
Right. Yeah. So now you're throwing more antibiotics on top. And anyway, you do that a lot. And this bacteria will be like, this is awesome.
I recognize
Exactly. I recognize you. I can fight you off. So it's like this battle inside your body between the bacteria and the antibacterial Okay, so ways to prevent resistance, right? What are ways to prevent resistance? We should all know this with COVID. Come on. What are ways that we can stop the spread? Wash our hands.
Stay 6 feet apart.
Stay 6 feet apart.
Wear gloves.
Wear gloves, especially if you're a nurse and you're going into any patient room. You're going to touch any patient. Wear gloves. Do you guys still want candy? I still got it. No? You guys are all candied out? Okay, that's fine. Yeah, you can wear a mask, right? Especially in the ER, you don't know what's coming in. Debbie can probably chime in, and I don't know where big blue button is. Clean things regularly.
Open a door.
Where are we?
Wipe your hand.
This one? No. This one? Okay, so clean things, wash your hands,
Wipe your phone.
wipe off your phone. Keep your phone out of the bathroom, please. Like, pet peeve, selfies in the bathroom, guys. And in the car. I don't understand selfies in the car either. Maybe one of you guys can explain it to me. I don't know.
It's your downtime, you got nothing better to do.
In the car?
Ever.
There's nothing around.
I've been sitting at this light for 20 seconds. I can't handle it. Yeah, so keep your cell phones out of the bathroom. Wash your hands. Stay away from sick people. When you go to work, clean your space, especially if it's shared. Like nurses' stations, when you're doing shift change, wipe off those computers, your keyboards, your mouses, mice. Right, so there's a lot of ways to do it, right? Use antimicrobials wisely. If the doctor says it's probably a viral infection, please don't fight for an antibiotic. Unless they'll tell you, they're like, if it doesn't get better, in 5 days or a week, come back. Right?
Post passive aggressive memes on Facebook.
We're just aggressive.
Okay, all right. Patient education. Okay, Mark, you talked about nosocomial infections. What are nosocomial infections? Hospital-acquired infections. So infections that people get while in the hospital. You guys, the hospital is dirty, right? People think they walk into a hospital like, oh, it's so clean. That's where all the dirty people, that's where all the sick people are.
Everywhere else is acceptable.
Like I thought about it at my desk.
Right, Mark? Ugh.
His wife was sleeping on the ground with their 3-year-old on blankets.
Oh, you'll see that like it.
You see that in peds all the time.
They won't before COVID, you won't let the whole family back there. They'll just camp out. Oh yeah, it's disgusting.
Yeah, people that walk around barefoot in hospitals or even just with socks on, I'm like, get your freaking shoes on. That's nasty.
Take your socks off in bed.
Ugh. Right?
I wear
Anyway,
socks in hotel rooms.
hospital.
Give them a new pair. I'm like, take these off. They have them open. Like, I'll just wear these out.
Yeah, hospitals are really dirty places, guys. Promise. So, lot of different ways to acquire nosocomial infections. And the hospital has taken huge measures to try to prevent these because, let me tell you, your patient gets a nosocomial infection, insurance will not cover it. The hospital has to cover the treatment of it. Because technically it's the hospital's fault. They got the infection. Well, hopefully the patient isn't sleeping on the floor. Right? So that is, for all those who are at McKay and cry and complain that you can't place Foley's, which I totally support you in that. However, that is one reason why McKay and Intermountain won't let you guys place Foley's, is because of these nosocomial infections. They're trying to curb them. They're trying to stop them. Okay? So you can get them from patient flora, invasive devices, medical personnel, medical environment, not properly cleaning stuff, not doing care. Okay, so the 3 major hospital-acquired infections. Victoria said one. This was the MRSA. We have VRE and then we have VRSA or VRSA. So we've got.
The order of the most common ones.
In my experience, I would agree with that.
I see MRSA a lot more than I see
Yeah.
VRE or-
Yeah. And they actually, I don't see VRE very often. I don't see VRSA very often. There is also one that starts with a C, and maybe Debbie can, if she's still there, she can chime in. It's like what's it called?
Oh, everyone's trying to get.
I'm walking around barefoot, right? Not C. diff, Brooke. It's, although C. diff is becoming more and more.
Like Gloucester or whatever one. No, that's
Wow, I did that first.
Start with a C.
There's an acronym and it starts.
crabs.
No, not that. I'll have to look it up. There's one, it's an acronym, starts with a C. But we had one at McKay on medical and they were a 1-to-1 because it's a bad one and it's pretty contagious. So they were always a 1-to-1. I'll look it up for you though. I'll get it for you. But anyway, these are probably the most common, MRSA especially. And before this whole COVID thing came, McKay had, I just work at McKay, so I know, but they had a policy that if anybody was diagnosed with MRSA within the last 8 years, they were on contact isolation or contact precautions.
You're talking about the central line associated, or are you talking about like
No, I think it was like not CMV, because that's the.
Carbapenem resistant.
Ooh, maybe that was the one.
CRE.
CRE.
CRE. Okay.
Okay, that's the one. CRE. That one's pretty bad. Because carbapenem's
That's like E. coli and stuff.
carbapenem's like a big, big gun. Anyway, what was I saying?
Sorry.
No, you're fine. Oh yeah. So anyway, so it was 8 years. If you were diagnosed within 8 years of MRSA, then you had to be on isolation. Then it went to 5 years, and now with this COVID and the lack of PPE, they're like, just kidding if it's a current infection.
Yeah. By the way,
So-
we're seeing masks everywhere.
Okay. Should we take a 5-minute break?
Wait, I heard about the shoulder.
Okay, we're gonna take a 5-minute break.
No.
Let everyone hear.
It's so fast the other night.
Yeah, Brooke, to conserve PPE. Yep, that's exactly right.
Hell yeah.
All right.
His whole discography.
Love you, JT.
So let's go back really quick.
Oh god.
And let me just reiterate something that is on this slide, but we didn't talk about.
Uh-oh, going back.
This might be a wink moment. I don't know. I'm just saying.
Let me get my
You've been waiting all morning for a wink. Here is a wink.
Okay, ready.
Taking the full prescription and don't renew if the infection is gone. Oh, I guess it's not on the side. That's what I thought it was. But let me add something on here. Sharing prescriptions.
Oh,
Which, if you share, you will not be able to take your full prescription, right?
People should be fined if they don't take the full prescription.
Sharing prescriptions adds to resistance, right? Okay. So I need to say that one more time. Did y'all get it?
Sharing antibiotics.
Yes. Okay. All right. Okay. All right. Now we can go on. Let's see. Where are we? You talking about that one? Oh, process for selecting the correct antibiotic. You go into the doctor and you're like, doctor, I got this sore throat and I got a fever and I got a cough. What do you think they're going to do? They're going to swab your throat. right? Okay, they're gonna collect a specimen, right? Especially with a throat and a fever and stuff, because what could it be? Okay, before 2020, what could it be? Strep throat. Strep throat is bad. I had a girl. I used to work at Primary Children's too. I was a pharmacy technician in their pediatric ICU. Did I tell you guys that? Now you know. Long time ago. Okay, so we had a little girl. She was 13, 14? Oh, maybe she was 15. Lies. I think she was 15. She was a cheerleader. Sweet thing. She got strep throat. Mom never took her to the doctor. Just thought it was like just this, oh, sweetheart, it's a sore throat. Live with it. What? Yes. So it got really bad. She got septic. She came in. She was crazy sick. Came into the ICU. She was put on norepinephrine, dobutamine, dopamine, epi. What does that all do to you? What does it do to your peripherals and your blood flow?
Oh, it constricts it. Yeah.
It shunts it all to your center, right? Because that's the most important part. She ended up losing her feet.
What? She was a cheerleader?
She did, yes. She was a cheerleader. I think she lost some toes on one foot, and then she lost like her whole foot on the other because she was that sick, and it was because of strep throat. So
Not mono.
not mono. Not mono. But strep. So strep is not something to play around with, really. So that's one reason why they have those rapid strep throat tests, right? Which aren't 100%, but at least they give them a little something. They do the rapid and then they send it off for a real culture. Anyway, so you got to do that. Now, what do they do in the hospital? Well, with collecting specimens. Draw labs. For the love, guys, I'm going to say this multiple times. If you are a nurse in the hospital, do not give an antibiotic, an antiviral, an anti-infective until you get a culture drawn. The first time you do that, you're going to kick yourself for 3 days. And the doctor will kick you for 3 days. 6 days total, consecutive. Congruent, what is it? Congruent or congruent, right? Whatever. Anyway, please, if you give an antibiotic and then you take a culture, it will screw that culture up. I promise you, it happens all the time. So if somebody comes in sick and they order an antibiotic, and you know or you wonder if a culture has been taken or is needed, please contact the doctor first and say, do you want a culture before I give this antibiotic?
Or have you been taking an antibiotic?
Right. Or was a culture drawn? Like, make sure it's drawn, or make sure they want to order it. Or if they don't want to, document it, please. But that's very, very, very important. I'm going to say it again. Take a culture before you give any type of antibiotic.
Darn it.
Okay. All right. By isolating the infectious organism and it helps identify the most effective antibiotic. Okay, most cultures take 36 hours because they have to put it in a petri dish and then it has to grow. Have you guys seen how a sensitivity is done? Okay, so let me explain this to you. So what they do, maybe I should have got a picture of it, but found a picture. But they have a petri dish and they do a culture. They take that sample and they spread it on the petri dish for those who've had microbiology, right? And they sit it there in optimal environment and they let that sucker grow. And then they look at it under a microscope and they say, it's a gram-positive, blah, 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 blah. They take that organism and they spread it on another petri dish, and they have little discs of antibiotics. And they stick those little discs around this petri dish. And then they set it in the optimal environment again, nice, warm, moist, right? And it takes takes a day or two, sometimes weeks, to get this organism to grow, and they pull it out and they see if the organism has grown around these antibiotic discs. And if they haven't, then that organism is sensitive to that antibiotic because that antibiotic won't let it grow. Does that make sense?
Mm-hmm.
And then the ones that just grow and around these discs of antibiotics, those are non-sensitive because the organism has resistance to those antibiotics. Pretty cool, right? That's why it takes so long.
Is it 36 days just while they let it grow, or 36 hours just let it grow, and then plus the time to see which?
So it depends on the organism, because some grow faster than others.
Something they can speed up.
Yeah, and some they can speed up. A lot of times you have a culture and sensitivity within like 36 hours, usually. But depending on what it does and when it comes out, it can take several days to weeks. So once we collect the culture, then we start the antibiotics.
Oh,
So these just like not just for, but like in more serious situations, because like I remember a bunch of times going to the doctor and it's just like, oh yeah, here's amoxicillin or whatever. Like that day, they're not doing cultures and all that stuff. So is this just more for like the more serious stuff?
It depends. I know if a baby comes in with a fever, even if they don't look sick, if they have a fever, they do the whole gamut. Sometimes they'll do that. They'll say, hey, you're sick. Let's give you some amoxicillin. Most often that'll take care of it. But say you take it all and you're still sick, you're going to go back and they're going to say, okay, maybe this isn't what I thought it was. Let's take a culture, which may or may not be affected by the
Something like
amoxicillin.
efficiency and like cost effectiveness and stuff like that. Like
Yeah.
that on everybody.
Yeah. And then they'll, maybe get a culture and sensitivity, switch up the antibiotic. A lot of times with strep, especially with this whole movement to stop the overuse of antibiotics, they'll, and like I said, the rapid strep isn't 100%, right? But they'll do a rapid strep, say it comes back negative, they'll send you home and just say, hey, just, take care of it. Within a day or two, they'll get the sensitivity back, the culture back, and they might call you and say, just kidding.
Yeah.
It's positive. Well, you need to get on antibiotics. And they'll do it that way.
Like for like CDC purposes too, like they gotta try to do the best they can, but
Right.
like an outbreak of a specific bacteria or something.
Yeah. And that's another thing. If they find that there's an outbreak and they are constantly seeing this strain of strep or this strain of staph or whatever it is, then they might, you might be the fifth person to come in. They might just be like, oh, we know what this is. Take this. If it doesn't work, come back. But, because you'll see, it's just like the flu or the common cold. Everybody tends to get it. It's like this outbreak of the same thing. Okay, so here we have our broad spectrum antibiotics and our narrow spectrum. So you can kind of, by the name, guess what they do. Broad spectrum is gonna kill a lot of them. It's gonna do a lot of wide variety. Narrow, it's gonna kind of more hone on special groups. Okay, smaller groups of these pathogens. So a lot of times in the hospital, you'll see people come in, they'll throw them on a broad spectrum. They'll get the culture and sensitivity, throw them on a broad spectrum antibiotic, and then once they get the organism back, then they can say, oh, okay, we don't need this broad spectrum. We can go to a narrow one that's specific for this organism. That helps cut down resistance. Do you understand why? Okay, yeah, because we're throwing them on a broad spectrum because we're like, we don't know what this is, but we need to start controlling it. And then we find out what it is, and they're like, okay, now, we don't need to get an antibiotic that kills 20. We just need one that kills this. Okay. I'm just going to switch over let's see. An extended spectrum. What? What did you say? Oh. I would assume an extended spectrum is similar to a broad spectrum.
It says it's.
Does it say it in the book? Did I miss that part?
Yeah, on page 346. On the very bottom.
Oh, okay.
Extended. So, like longer?
Yeah, it sounds like they're
Sounds like
a little in
more
between.
in-depth, yeah.
But as for this, we're gonna concentrate more on broad and narrow.
That medication she's talking about.
Zosyn.
Yeah. So is it like broad spectrum then?
Yeah,
Or
you
it
could
is a
consider.
broad
Yeah,
spectrum.
yeah,
Yeah.
yeah. In the hospital, they talk about broad and narrow. They don't really ever
But it's
say
got some,
extended,
like,
but
a couple that are specific.
So it is kind of in between or no?
So it's a broad one, but then it also has a couple of extra like specific ones that are cool. Yeah.
So it like includes all the ones that the broad one does, but also.
Yeah, a
specific
couple
ones
extra
to put in with
specific
it.
ones that are a
Okay.
little harder to write.
Yeah.
I see.
Okay.
So it's a broad extended.
Yeah, it's like, yeah, broad one.
Plus some.
Oh, boy.
but I don't think you'll see the word extended spectrum in your test. It'll be either broad or narrow.
Thank you. So it's broad.
Consider it broad, yes. Okay, so the patient enters the emergency department with a draining wound. Once the patient is admitted and assessed, the priority nursing intervention is to culture the wound. Culture the wound first, right? Right. What if the doctor's like, hey, I need this antibiotic given now?
You want to culture first?
We say.
Exactly.
No.
Exactly. Say, I will get it as soon as I get that culture for you. Trust me, they'll thank you. Even if they're mad, they'll thank you later. Okay. Okay. That's absolutely. And then enforce droplet isolation precautions. Why not that one? Not droplet, right?
I mean, contact is like disgusting.
Right.
but-
It's a draining wound. You definitely want isolation precautions of some kind, whether it's gloves or gowns or, drop or goggles. Droplet, it doesn't need to be droplet. Okay. You don't need to teach the patient about the ordered antibiotic because you're not giving it yet, right?
Add things to it.
Okay. So anti-infectives may be given to prevent infections as well. So they can be given prophylactically in specific situations, such as animal bites. Okay, surgical procedures. Pretty much anybody going into a surgical procedure will have an antibiotic ordered and given 30 minutes before. Mark, with a K.
So like my family just got their wisdom teeth taken out and they didn't give them any types of antibiotics. So I was just wondering like why they didn't do that for like wisdom teeth. It's kind of like off topic.
Well, it's not really off topic. So, unless they found that at least with teeth and with pulling of teeth, unless they have an active abscess already, you usually don't need antibiotics.
Okay. So, yeah, that's what I was like confused. Like when they gave them the medication, it was like painkillers. I was like, did they give them like some type of antibiotics or something? Because it's like there's a lot of bacteria in your mouth. So it's like,
There is a lot of bacteria in your mouth.
but then
Your mouth is
I'm not a doctor. So
Pretty dang dirty. No, yeah. So, my daughter had an infection in her jaw and had to get a tooth pulled, and she got antibiotics then because she already had an active infection. Now, if whoever got their wisdom teeth out, if they developed an infection, they would throw some antibiotics on. But as far as just a routine tooth pull, doesn't necessarily need antibiotics. Now, if they had to go in and like surgically cut them out and like drill them out, because sometimes they can get impacted and it's a pretty fantastic procedure, they might throw in antibiotics on top of that if it was, severe enough type of surgery type thing. But yeah, just a routine tooth pull. Yep, perfect. Now, an exception to that.
Keep that for online. I don't know if they know what we're talking about in here. Online class.
Not usually. If they were in class, they could hear just fine.
Right.
Just saying. She was just saying pretty much the same thing, just that if it's just a routine, if it's something routine, they don't need antibiotics. Now, the exception to that, as far as the dentist goes, is for somebody who's had heart problems or what is it? What's that? Like a valve replacement, any type of heart surgery, rheumatic fever that affects the heart. If they have a history of that, then they would take antibiotics prophylactically before going to the dentist. Yes, Olivia. Yeah.
I think epi. I don't know why. Endo.
Endocarditis. So that would be an exception as far as the dentist goes, because last thing you want to do is get an infection in your heart. Don't want to do that. Amy.
Sorry, going back to the previous slide. So the anti-infective is basically an antibiotic. Those terms are used interchangeably.
Yes. Are you talking about this one or the one before that?
No, like way back.
Oh, way back.
When you gave the definition of anti-infective, I just wanted to understand.
Yep. Antibiotic, anti-infective, antimicrobial. Interchangeable. Okay. Prophylactically for travel, depending on where you're going, and then immunosuppressed patients. You need that extra boost. Okay. So as far as getting an anti-infective, host factors can affect your selection, right? Who's the host? We are. The person that's sick, right? Pathogen is the thing making us sick. Okay, so the doctor might change things up if you're immunosuppressed. Okay. If you have tissue conditions such as necrotic skin or inflammation, obviously allergy history. If you're allergic to penicillins, those are off the table, right? Can't take those. Age, pregnancy status, some of them you can't take when you're pregnant. And then genetics, of course. So a lot of different reasons why. Okay, now common adverse reactions, and we're going to go through this before we even talk about different meds because they're common. Antibiotic adverse reactions. So we have our allergies, which is just a simple rash, can be itchy, a little bit of hives, not too bad, up to anaphylaxis. Okay, so some people can just have if I take amoxicillin, I just get itchy. Other people are like, I could die. Okay, we're going to talk about super infections. That's with C. diff. That's when our good bacteria is killed off, and then we get our opportunistic pathogens coming in, causing problems. So it really depends on the person. So some people you can, if it's their first, especially if it's their first time getting antibiotics, definitely want to watch them. Okay. Kids or, say somebody's been healthy all their life and then just needed something. Anyway, if it's their first time, definitely watch them because it can start to just like a little rash, or when you give it, it can go straight to anaphylaxis. So, I mean, and then everywhere in between, right? Now, if they have, we did have one little kiddo who's getting a septic workup, and when they do that, they do like their blood cultures, they do an LP, lumbar puncture, they send off all those things, and then they throw on like 4 different antibiotics. And then when we get the tests back, they, take them off or change them. Well, this little kiddo was on 2, and he ended up, he was on 3, I think, but he ended up getting a rash. It was just little, and then as the day progressed and he got more doses, it got worse and got worse. And so we were trying to figure out which antibiotic was causing this problem. So sometimes it can be a little tricky, but if it, he didn't go into anaphylaxis, which was fine. So, but sometimes if they're on multiple and you throw them on there and then they start getting a reaction, it's a little tricky to figure out which ones. They can also cause organ toxicity, kidneys, liver, and then the ears as well. Kidneys and liver, man, they get beat up with almost every med, right? Okay, superinfections occur when an anti-infective antibiotic kills the host's flora, the good flora, right? The stuff in our gut that is helping keep everything balanced. Because like we said, they're not selective. They just go through and just kill everything. Okay. So, and then like we talked about before, broad spectrum antibiotics are more likely to cause superinfections. So what are some superinfections, can you think? We already talked about one. Or so, let's see. Well, what's the other one though? C. diff. What else? Could be, I'm looking more towards like fungal infection. Yeast infection. There we go, Mark. Yeast infections. So either vaginal yeast infections or oral yeast infections, which is thrush. Good job, Mark. Okay. So when host flora is destroyed, additional nutrients and space are available for pathogens to grow unchecked, right? Our body is, our good and our bad. They're always trying to even each other out and keep each in check. Because too much good is bad too, right? Okay. I know you're all agreeing with me.
Yep.
So there's your Clostridium difficile, the C. diff, Clostridium albicans in the vagina, which is your yeast infections, and streptococci in the oral cavity. Signs and symptoms of superinfections. You guys probably want to star this slide.
The whole thing? The whole slide?
Is it what's there?
1 year?
There's not that much on there. The first bullet point is what a superinfection is, how it comes to be. The second one are what they are. And the third one are signs and symptoms. All things you need to know. Right? So you can get diarrhea, bladder pain, painful urination, abnormal vaginal discharges. Even with the mouth stuff, you get sores in the mouth and the white patches, right? Right? So what are some things to help combat that? Other medications. Diflucan. Metronidazole for the C. diff, stuff like that, right? The patient asks the nurse why she gets yeast infections after a course of antibiotics. The nurse explains, do antibiotics lower your white blood cell count?
No.
They don't do anything with that, right? They don't affect it at all. People are poorly nourished and hydrated after an infection. Sometimes, but not always, right? So that's not true. Yeast infections happen if the antibiotic is not taken for the full course. Perfect. These infections are common when the normal body flora are disrupted.
That's why you should take probiotics. You don't get these infections.
Right.
Frequent douching.
Yep.
No, I don't do it.
Perfect. Okay.
Don't use good things.
All right. So now we're going to get into the drugs.
Throw out your gauge.
Okay. Antibiotics affecting the bacterial cell wall. Here we have our gram-positive, our gram-negative, and all the stuff that goes with that. You don't need to know. I mean, I'm just showing you the difference between gram-positive and gram-negative. You don't need to memorize all these layers. It's just a fun picture. Okay. I want to make you.
That's my grade.
A C positive or a C negative? All right. We talked about this. Who's this guy?
Oh, you discovered the penicillin, right?
Who is he?
I forgot his name.
You forgot his name.
Lemmy.
He's as important to the medical field
Great. Jonas Salk.
as Florence Nightingale.
Or Madison Fury.
Florence Nightingale.
Alexander Fleming. I assume that's a picture of him. I really don't know, but I'm assuming.
It's a young person.
That's a young king right there.
Kind of a big deal.
Okay. So it's one of the oldest, one of the safest groups of antibacterials. These penicillins. They're primarily good against gram-positive bacteria. Oh, people are on the ceiling again.
That was annoying.
Son of a. I'm like, what is happening? Okay. First administered therapeutically in 1941. That's when World War II happened. So it was like a fantastic, optimal time to get this penicillin.
That was the number one death.
Right. Yep. So now we can curb that. And not as many people, still a lot of people died, but not as many people would have died if you added an infection on top of that. So there you go. So the penicillin lyses the growing bacterial cells that are growing cell wall. So they just basically like poke holes through these cell walls. Okay. They lyse the growing bacterial cells. Okay. Then we have this beta-lactam ring, which is the chemical structure of penicillin that is responsible for its antibacterial activity. Okay. It's these guys right here. These are your beta-lactam rings.
I see you.
Okay. All right. So,
Christmas tree.
did I say? Okay. We're all on the same page. Gram positive. I thought the other one said gram negative, and I was like, wait a second. They both say gram positive. Okay. They have a narrow spectrum. They are widely distributed to most of the body tissues. So you take them, they're going to go systemically rather well. Yep. So if you have a meningitis, you might not go for penicillins. I'm sure there's other ones that reach the CFS a little bit better. Okay. Excreted by the kidneys, and they have a short half-life. Okay. Allergic reactions are the most common. Oh, I have two I's in there. Penicillins. Anyway, most common adverse effects are these allergic reactions that we talked about before, the most common ones. And if people are allergic to antibiotics, it's most likely going to be penicillins. What's the mnemonic? What is it? A mnemonic? What's the shorthand of penicillin? Like if a nurse was to write like allergies penicillin, how would you see that? Close. PCN. Usually shorthanded as PCN, penicillin. Okay, so reaction can occur anywhere from minutes to weeks. So this also means, and this is with a lot of drugs too, is you can take this drug and be totally fine. You can take it a month later and get an allergic reaction.
I know that guy.
She was way too close.
I know. A little intimate
Not
there.
6 feet.
What the heck? What am I missing outside?
Some tea. Oh, hey there, girl. Your social distancing.
Was it? He offered me a hug and I said yes. Side hug though. He's my work husband.
Your work husband. Why not your real husband?
Because he's married. Yesterday I was making him a honey-free list. And I'm like, does this kind of feel like I was making him a list. And I said, does this kind of feel like a honey-do list? And he's like, yeah, a little bit. And I was like, well, maybe you could just be my work husband. And he's like, that's fine.
Hello to my friends online. Hello, friends online. It's fine. I mean, hello. I just wanted to say hi. Love you all. Love you. Love you. I look good in this light. Yes. Okay. Yes. Yes, I've heard that. Okay.
Okay. We started
Alright.
cheating on Rachel. We saw that.
She's my work wife.
That's my work spouse and you need a spouse. I need a real spouse. My eye open for you, Jody.
You're my girl.
Thanks. Love you guys.
Okay. Also, if carrying on. Also, if you have an allergic reaction to penicillin, you have a higher risk of being allergic to other
All the cylinders.
types. Well, yeah. So you would be considered allergic to all the medicine in that class, but you also have a higher chance of being allergic to other classes of antibiotics as well. Okay. So here are adverse effects again. Mild rash, and it can go for anywhere from mild, irritated, itchy to a severe rash, like breakout and hives. Pruritus, diarrhea, nausea, fever, compared to anaphylaxis.
Oh, fun.
So let me tell you a fun little story about penicillin. What?
I said Malta.
Okay, before we get to penicillin. So,
You gotta watch the one I did.
well, maybe I'll do it with amoxicillin because
I know, it's actually, yeah.
I'll tell the story with amoxicillin because that was the drug.
It's because he did the final stretch.
Okay,
But everybody does both.
so we have penicillin G. Now there's two different types of penicillin. There's penicillin G, there's penicillin V. Penicillin V really isn't, well, and penicillin G, they're really not widely used anymore. Why? Why? Why do you think?
Bacterial resistance or whatever.
There you go. They used it all the freaking time. So they have a lot of resistant bugs out there to penicillin. Okay. So penicillin G.
It's not used as much because of bacteria or antibiotics resistant.
Yeah. Yep. So penicillin G is administered IM or IV. This is the big penicillin shot in your butt. Most people get in their butt because it's big. The big shot. Now it's painful. It's a painful shot. So a lot of times they, instead of like diluting it with just like NS or whatever, because it's a powder you have to mix up. Anyway, they'll throw in some lidocaine in there as well, which makes it thick. It's thick. It hurts. Okay. Let's see.
That's what they call the peanut butter shot or
Just think it's peanut butter.
It could be. I've never personally given penicillin G, but I know it hurts. It's a painful shot.
like the biggest.
And it's thick, and yeah, they put lidocaine in with it just to help. There's a few of them that'll do that. Okay, drug similar to penicillin G is penicillin V. It's nearly identical, but it's more acid stable, so it can be administered PO.
So this one would be used more commonly then.
Yes, but still not commonly used. So well, I should say little known facts, but some facts about it. Taken on an empty stomach. It can be cautious with potassium sparing diuretics. Knowing this, what do you think? What can you maybe assume that penicillin V does? Hold on to potassium, right? And it's got potassium in its name. Just saying. Okay. Piperacillin. This is your extended spectrum, but like I said, you're going to hear broad or narrow. Piperacillin tazobactam is Zosyn. What was that?
What is that back then? You said that's Zosyn?
Tazobactam. Yeah, brand name is Zosyn. Zosyn. Good for a whole lot of stuff. It can cause a lot of problems too. You guys can read all that. Okay. Let's see, we've got our penicillin group. We've got penicillin G, we've got penicillin V, and we've got piperacillin. What can you assume are like penicillins under that group? Perfect. Their name ends in cillin. So amoxicillin is going to be under the penicillin. Okay. Aminopenicillins, right? Let's see. Ampicillin. So anybody allergic to penicillin is not going to get amoxicillin, ampicillin, anything that ends in cillin. Okay. Let's see. Some of the most widely used antibiotics for sinuses and upper respiratory and GU infections. Genitourinary. I just got to read it. That's all I got to do. Okay. Here's your ampicillin. You're gonna see ampicillin. I know a couple people in my clinical group have mixed ampicillin. Anyone else?
Then what?
Mixed ampicillin.
Was that like the powder you like squeeze the whole thing into it and mix it around?
That's usually Zosyn. Zosyn comes that way. So ampicillin will come in a vial, and you have to put your NS in to mix it. Who? Oh, I know. It was a student I had the other day that did it. I'm like, somebody just did it. It was a student I had at work. Yeah. Yep.
Are pretty much all these cillins gonna have like the same side effects and everything?
A lot of the antibiotics will. Now, there are going to be some antibiotics that have kind of their own thing when we get to tetracycline. It has its own little thing, but you can refer back to the common side effects. It's going to be diarrhea, nausea, rash. Okay. So, use cautiously with people who have renal impairments. Also, pretty much all antibiotics decrease the effectiveness of contraceptives.
Yeah.
This is huge. Huge to tell women of childbearing age, if they are on an antibiotic, they need to have another form of birth control. It could be a wink wink.
Okay.
Can you say that one more time, please? I didn't understand it the first time.
All antibiotics will decrease the effectiveness of oral contraceptives.
all the antibiotics.
Pretty much. You can assume that this is, I wouldn't, if it were me and
You don't want any disease.
my husband hadn't had a vasectomy, I would definitely, any antibiotic, have another form of
That's good. You took one vaccine.
contraceptive. What? Oh, yeah, I know, right?
Best day ever.
Abstinence, there we go.
That works. Abstinence, condoms,
Divorce.
divorce.
Divorce will do it. Kids.
Hopefully the divorce is not because of the antibiotic, which could imply other things, but no judgment. Anyway. Anyway. You know, I don't know why it just does, and it's very, very important to know. So if you're working in a clinic or even in a hospital and a woman of childbearing age is going home on an antibiotic and they're sexually active, tell them that they might have a baby.
Only
Oral contraceptives, right. IUDs, it doesn't seem to affect. If you've had a tubal ligation, you should be good. Probably not because of the antibiotic, though.
And that's like a big deal with like teenagers and young adults too, because they'll take it for like acne and stuff and other reasons.
Uh-huh.
And they're like, oh, I got pregnant.
Right. So if they're taking it, if they're sexually active and they're taking it to prevent pregnancy, let them know.
The condom on the banana.
I never did that in sex ed.
Put it on upside down, you gotta throw it away.
I never did that. Okay, watch for diarrhea. It's very common. Also, guys, with diarrhea, let them know. Chances are you'll get diarrhea. Okay, drug similar to ampicillin is amoxicillin. Has a lot of the same characteristics. It is destroyed by penicillinase producing organisms. So we're going to talk about how we go about going around that. Okay, right. Okay. We talked about those enzymes that can stop the antibiotic from killing. This is one of those enzymes, the penicillinase. Okay. Let's see. A lower incidence of diarrhea, but I'm telling you, it still happens. Largely replaced ampicillin and one of the most frequently prescribed antibiotics. And that's true. That's the type of bottle we get in the pharmacy, 500 capsules, and we usually have like 3 of them on the shelf because it's so widely used. Okay. So hold on real fast. Let me tell you a story about my daughter with amoxicillin. So she was 7, I think, and she's getting her tonsils out. And she was the first time taking really any antibiotics. I have healthy kids pretty much. And so when you get tonsils out, you have, your antibiotic and your steroid. Right? So she's on a steroid. She's on antibiotic. So she's on the steroid for 10 days, and I think the antibiotic for 7. So we got done taking the antibiotic for 7 days, continued on the steroid, was done with that, and then all of a sudden, she broke out into this rash. Like, massive rash, like all over her arms, her trunk, her front, her back. And I was like, what?
Did the steroid prolong the allergic reaction?
Exactly. So the steroid suppressed the allergic reaction to the amoxicillin. So the whole time she's taking the amoxicillin, she's taking right, exactly. She's allergic to it. There's no response because the prednisone, the steroid, suppresses the allergic reaction, right? Now, just because you're taking an antibiotic for 7 days doesn't mean that it's not still in your system and working days after, right? So she still had it in her system. The prednisone cleared faster than the antibiotic. And so even me as a nurse, days later, I'm like, why is she getting this rash? Anyway, it turned out she's allergic to amoxicillin, but I didn't know it till days later.
So she can't have any stones.
Right. And I don't know because, like, if you think about it, she had less amoxicillin in her system, days later than she would have just while she's taking it, right? But she still got that big rash. So I have no idea what her actual reaction would be without the penicillin or without the prednisone.
So every time she has amoxicillin, just give her prednisone. Yeah.
Well, I actually put on her profile she's allergic to penicillin, so so they have to do something else. But pretty interesting, right? I thought that was pretty interesting, having that happen to my daughter. Okay, so combination drugs have been developed that offer certain advantages over single drug therapy with immunopenicillins. Here we have Augmentin. Okay, so this is Augmentin is what? Amoxicillin with clavulanate potassium. What do you think clavulanate potassium will do?
Anything to do with the heart.
Yeah.
Just like a carrier kind of.
You're getting closer.
Help.
Let's see what the next slide. Oh. Okay.
Yeah, like how carbon below helps.
Ooh, you're getting there. You are getting there. So she kind of likened it to carbidopa levodopa, where it's a carrier. So here's what happens. So remember when we talked about resistance and that this bacteria can develop enzymes that destroy the antibiotic? The clavulanate potassium, is like a protector against those enzymes. So it'll come and it protects that antibiotic. These enzymes come and try to destroy this antibiotic, and it's like a shield. It says, no way, you're not going to destroy this. So then it makes that amoxicillin be able to go in and destroy the bacteria. Isn't that cool?
That's cool. Oh yeah.
Right?
They got their outer
Their shield.
the things that they get into, right? So they're gonna like some big thing.
Oh, are you talking about the Power Rangers still? Right? Right? Exactly. They get into the big machine because now they've got all these.
They've got the extra layer of protection.
There you go. There you go, Mark.
So all these drugs that we're talking about, amoxicillin, ampicillin, augmentin, these are all broad spectrum.
Pretty much ish. Yeah.
I'm just trying to find a way to categorize these.
Yeah.
So let me tell you, like on a test, they should have, so we should, I think it's this way on the NCLEX too. If they have the brand name, they'll have the generic with it. Usually they've kind of gone away from using the brand name anyway because it's more company specific, right? And they don't want to endorse any type of company. So if they have a brand name, they'll have the generic with it. And that's the same with my tests. Or I might not have a brand name. I'll just have the generic. So you can still do the Cillin thing with penicillin, because I'm not going to say Augmentin. It'll say amoxicillin clavulanate potassium.
Okay.
And so then you'll know, oh, that's a combo drug of a penicillin. Does that make sense?
Yeah. So I think the question was most of these are going to be broad spectrum that we're talking about now, right?
For now.
Yeah.
Once we get into the bigger antibiotics are going to be
More specific.
More
It'll say,
specific.
this targets this kind of organism.
Yeah, but I'm not going to grade on that either. Or I'm not going to test on that. I'm not going to say, okay, you've got E. coli. What medicine are you going to give? You know what I mean? So I'm going to test on the antibiotic, not on the specific organisms. Does that make sense? Okay. Right. This is not path though. You don't need to Oh, look. Oh, look. A test on contraceptives. A question on contraceptives. Okay, which instructions should the nurse give a 21-year-old female patient being treated with ampicillin?
Definitely A.
Stop taking them because serious side effects could occur. Use oral contraceptives as prescribed because antibiotics don't react with it. Antibiotics may decrease the effectiveness, and antibiotics, when taken with oral contraceptives, causes toxicity. Free, right. It may decrease the effectiveness of oral contraceptives. Shut up, Kim.
You're fine.
I swear, if anybody gets the question wrong on the test, for the love, I will automatically fail you. Like, there's no coming back. I'll lock the door. You won't be able to come in. Okay. Antibiotics decrease the effectiveness of oral contraceptives. I think y'all got this. Okay. All right, that's penicillins. Of penicillins. Hey, we're doing good. We're doing good.
Corby, I have a question. Can you hear me?
And it's only on chapter 26, which actually is a longer chapter, but that's it. I know. I know.
Yeah, you guys have to put the vitamins in there.
Made them their own. Yeah. Their own.
I pretty much spelled out what you needed to know for vitamins, and you guys still got it wrong.
Vitamin C and iron. I got that one right. I did get that one right.
And I also said no to side effects and deficiencies of vitamin A and vitamin C, and you guys still missed that too. But you guys did much better on this test, by the way. Just saying. The rough average was 80.
Somebody on last week.
Question.
I think it was someone on mic. Was it Kylie? Kylie was saying something. Yes. Kylie, what's
It
your
was
question?
me, Brooke.
Oh, Brooke.
Yeah, can you guys hear me?
Speak really loud.
Maybe.
There we go.
Is this better?
Yeah.
Okay. I just was wondering, you said oral contraceptives, right? Not like as if they have like an IUD or like the shot thing in their arm or like something like that, then it doesn't affect the like effectiveness of those ones, just oral contraceptives?
Correct.
Okay, cool. Just wanted to like double check that.
Yep.
Why is that? Where the heck?
I know. It was Mapu, I think, wasn't it? Yeah.
I was probably for the.
Sorry. Teaching to the class. Come to class and you can ask your question right away. Okay. Cephalosporins. This is the largest class of antibiotics. There's actually 5 different subclasses underneath this one. They also contain a beta-lactam ring. Okay. So these also work for gram-negative. These work for gram-negative. I think penicillin is gram-positive, right? And for patients who are allergic to penicillin or have penicillin-resistant infections. However, this is kind of like you can kind of think of it as like a far cousin of penicillin. So you still have to be careful giving this to somebody with a penicillin allergy because they have a higher susceptibility of being allergic to this as well. Probably like a third cousin. A little closer than a sixth cousin. This is the go-to though. If you're allergic to penicillin, they'll stick you on a cephalosporin just because it's the next line. But you do have a higher susceptibility of being allergic to it than somebody who's not allergic to penicillin. That makes sense? Okay, good. Okay, so inhibits the cell wall by binding to the PDPs. Protein binding something. It's bactericidal. It kills them. So,
Protein binding something.
protein binding, blah, blah, blah. When I do this, I'm like, I'll totally remember what that means. And then I don't. I know, but and I feel like I'm like jumbling up these slides. Like making like a, you know what I mean? I feel like the less words I can put on a slide, the better.
Yes, I agree with that.
Okay, thank you. Anyway, basically just know they're bactericidal. Okay, 10-4. That's all we need to know. So classified chronologically by their generations. Like I said, there's 5 different generations of cephalosporids. Okay. The drugs within each generation have different chemical structures, routes of administration, and spectrums of activity. Don't worry, we're not going to get that into it. Okay. I got to tell you what this is because the book covers it, but like,
Penicillin binding protein.
there we go. Penicillin binding proteins. Okay. So here, first generation, we have cefazolin. Let's see. What do we need to know about that? Unable to cross the blood-brain barrier. Cephalexin, that is like, here we have amoxicillin mostly used. Next we have cephalexin.
Oh, this is not on mine.
What?
It's not on mine because I transport it onto like my notability thing.
Oh,
It's
okay.
just blank.
Just, handwrite all of that in.
Just my pen back.
Oh, okay. Second generation are more potent, less sensitive to the beta-lactamase than the first generation. Let's see. Most have been replaced by third generation, unable to enter the CNS as well. Here's a bunch of these other drugs. Like I said, you only need to know the drugs that are on that list. Not all of these are on that list.
So just like the bolded one then?
Just the ones on our objectives.
Yes. I believe cephalexin is one of them. There might be another one. I don't have my list here. Ceftriaxone should be on that too. Cefin is pretty popular. Ceftonir is Omnicef. That's pretty popular too. Let's see. Here's your salmonella. But it will help. Let's see. This one is able to enter the CNS. So if you have some kind of meningitis, Procefin is going to be your friend. Cefepime, 4th generation. See that every once in a while. Let's see.
Oh, yeah, you're good.
Yep.
Big game.
And then we have our 5th generation. Okay. Ceftaroline. What are you finding? Like, look at all of these and tell me what similarities they all have. Ceph. Anything in Ceph, CF, is going to be a cephalosporin. Okay? So we have our illins for penicillins. We have our cephs for cephalosporins. Okay. Which nursing intervention has the highest priority? They're all pretty good, but which one has the highest priority for a patient who's taking cefepime? We know it's a cephalosporin.
Listen.
So why is A probably not an answer? What?
We're not doing anything. We're just waiting.
Do you have to wait until culture's result to give an antibiotic?
No, just draw it. My bad.
Yep.
I'm on.
Tricky. Tricky. Now, when we get them back, they might change the antibiotic, right? But it's better to start them on something. And this is probably, let's see, cefepime. I'm assuming it's broad spectrum. More effective against organisms that develop resistance. Right? Did we talk about anything on here how to give it? No.
We also can't do IVs.
And you also can't do IVs. And then instruct the patient to take the drug for 5 days only.
No, until it's done.
Until it's done. And that's dependent on your order for the antibiotic, right? The doctors order it for 7 days. Some antibiotics take 3. That's a tri-pack of Zithromax. Or azithromycin, right? Some are done for 3, some are for 5, some are for 7, some are for 14. Some you take for months, right? So do we have a doctor's order? Do we know how long to take it? No, we don't know how long to take it. That wasn't given to us. We can't do IVs. And you don't have to wait for the culture to result. You just have to draw one before, right? Answer is B. You want to monitor the patient for signs and symptoms of a superinfection. Okay. What statement will the nurse include when teaching a patient about cephalosporin therapy? Avoid ingesting buttermilk or yogurt when taking this medication. Stop taking the medication when you feel better. Immediately stop taking the medication if you develop nausea. Or inform your healthcare provider if you develop mouth ulcers. D? How about all you girls up there? Yeah, D. Okay. All right, so let's just go through all the options. So A, avoiding ingesting buttermilk or yogurt when taking this medication. Right. Here's a wink wink. Yogurt. Yogurt is a great probiotic. Is that what you have, Emma? She's got yogurt. Yogurt is a great probiotic. It's easy to take. A lot of people like it. It's available at any grocery store. Okay. It's a really, really great probiotic. Especially for kids. You don't have to swallow any capsule or drink anything that's mixed. Right? Great probiotic. Yogurt. Great probiotic that will help with getting the normal flora back in your gut. Okay? Stop taking the medication when you feel better. No. Most people feel better on an antibiotic within 24 hours. Okay? You're still going to have to take them for days after, right? You're going to get sick again, I promise. Immediately stop taking the medication if you develop nausea. That's a common side effect, right? If they call and say, oh, you know what? This really upsets my stomach. There you go. Take it with food. Or what if they say, I have been taking it with food?
Change the food. What foods are you taking?
Okay.
With the yogurt, because probiotic will help with that stomach.
Okay. Or, depending on the antibiotic, sometimes you want to take it without food. So, and then inform your healthcare provider if you develop mouth ulcers. What is that indicative of?
It's like breaking down this.
What's that indicative of? There you go, Amy. A super infection.
Yeah.
I'm just actually reading your notes.
Any type of, right? Mouth ulcers, change in vaginal discharge, diarrhea that's really bad and won't go away and doesn't help, right, with the C. diff. Anything like that, super infection. Now, diarrhea is normal, but anybody who has experienced C. diff sometime in their life, whether with a patient or had it themselves, well, there is a difference. Okay. Carbapenems. Do we want to take lunch?
Yeah.
Okay. Okay. I'm at the edge of my seat waiting for lunch. Okay. Let's take lunch. We'll say 12:25. You get 35 minutes. Yeah. Okay. Take lunch. 12:25. We will come back. You guys didn't tell me I was muted. Oh, and my video isn't on either. Good grief.
Get it together, Corby.
I know. At least I remembered to record me not talking anything. What was that?
Man, it depends on who gets elected.
Are we talking about politics?
Mark had to go
All
there.
information.
Sorry, Alina, I was muted. My bad. So we're talking about carbapenems. I just read through that. It's the broadest antimicrobial spectrum. It's effective against aerobic, anaerobic. If you're getting this, it means you have a pretty big infection. Only given parenterally, and it's considered the last resort antibiotic.
You are recording, right?
I am recording, yeah.
Fantastic.
Maybe they can read my lips at the beginning of it. But I think I covered it all real quick, right? What I missed? Okay. So imipenem. Imipenem is a carbapenem. What?
No way.
They rhyme.
Somebody in science is smart when they do so.
Only a few people are smart. You get in those weird drugs and they have no rhyme or reason. Okay, so use cautiously with patients with brain lesions, head trauma, or history of seizures. I'm assuming it does something with your CNS. Well,
Or is that a wink wink?
I'm just assuming. Let's see. Drug interactions, penicillin cephalosporins antagonize the effects of this medication, decreases the levels of valproic acid, resulting in seizures. And then monitor labs and allergic reactions. Okay. Patient is taking this imipenem drug. Report shortness of breath, mouth and tongue swelling, and generalized itching. For which of the following does the nurse initially assess the patient? That's a weird question. I think that's a weird worded question. But
His blood is crazy. Yeah.
Never heard of it. That's on the-
blood dyscrasias, you haven't heard of those?
What is that?
Difficult.
They're like problems, like blood problems, like whether it's destroying or not. What do you think? What are all those indicative of?
Blood problem? I'm going with one. Like, I'm crying.
I'll go one.
Those are all like allergic reaction stuff, right? Anaphylaxis, shortness of breath, mouth and tongue swelling, generalized itching, right? We're going to assess for hypersensitive reaction. Hopefully they don't go into anaphylaxis. That's kind of what I was going through. Yeah. Yeah. Those are all saying that we have an interaction here. We have a allergic reaction. Okay.
Yeah, so there's a slide that's like.
What?
Above this apparently. The drug similar to, did you delete that?
Yeah.
After your,
I'd like-
chart one.
After that.
After that?
Says FYI, drugs
Doropenem,
similar to.
Doropenem.
And actually, if you go over at the slide, it has a little like cross out thing.
Oh, yeah.
Meropenem?
You didn't know this?
Meropenem?
I crossed it out.
Marrow Del
Yeah. How interesting.
I got skipped.
See how it's got like green cross out thing over there?
Yeah.
Let's just skip it for. Yeah. Moving on. Yeah.
How about I make a deal? If you need to know about it, I'll put it on the clarification document. Okay.
Thank you.
Sounds good. Sorry, it's not on mine.
Okay.
Okay, macrolides. These are also alternative drugs who are allergic to alternative drugs for patients who are allergic to penicillin. Okay. So, effective against gram-positive infections. So, whooping cough, diphtheria, Legionnaire's disease, strep, Haemophilus influenzae, Mycoplasma pneumoniae, which is actually more common than you would think. Mycoplasma. And then your good old chlamydia. It's really good for STIs.
Not for me.
Now I know what to tell the doctor I need.
I think you need to be more serious.
Oh my god! Like, oh cool, using that.
I'm embarrassed for you. That's great.
Everybody.
Very prominent thing to have, okay?
One of every 6
STIs, they're going around. Okay. Good for STIs, guys. Okay. They don't know who said it. They don't know who said it. Okay. Oh my gosh. Okay. That's so funny. Okay. So the newer macrolides have longer half-lives and they cause less GI irritation. So this would be like your azithromycin, if anybody's had a Z-Pack, right? That's for 7 days. Well, now they have a tri-pack, which is for 3 days. So yeah, so it's for 3 days. You have a Z-Pack, which is for 7. So the newer macrolides, they last longer, even though you're taking it for a shorter amount of time, and they cause less GI irritation. They should be taken on an empty stomach. A lot of them are enteric coated. But if all fails, if it does affect people's, like if it gets to where they can't take it because they're so sick, you can have them take it with food, but that's usually not needed. Okay, erythromycin is in this group, the macrolide group.
Are macrolides like their own thing?
Mm-hmm.
So then now we're going into erythromycin. Or is erythromycin a macrolide?
Erythromycin is a macrolide. A macrolide is a classification of antibiotic. So we're going to cover erythromycin, clarithromycin. I think those are the only two in this group.
What about Vanco?
Azithromycin. Vanco is a glycopeptide. So we'll get there. It's on our list of things to talk about. Okay, nausea, vomiting, abdominal cramping, take on an empty stomach. When given IV, you can get phlebitis, so be very careful. High doses can be cardiotoxic. Here's your hepatic impairment. It does have a lot of drug interactions. Grapefruit juice may increase the bioavailability. What does that mean?
It's gonna be more like, or more available, yeah.
Yeah, so it's going to be more in the bloodstream than.
Right, so we can get more adverse effects with it, right? I'm telling you, grapefruit, I think we've heard it every single lecture day.
But it's never the answer. Every shot is.
It was one.
It was once out of how many tests?
Okay, monitor bowel function, assess IV site. Here's a little tip for you guys, especially with antibiotics, because a lot of them can cause phlebitis. Your order, at least with Intermountain, your order will tell you how fast to give it. Give over 30 minutes. Give over 1 hour. You can always go longer than that. Especially with babies and kids, I always go longer. If it says it can go a half an hour, I usually do it for an hour. Because of this reason, the phlebitis. The slower you go, the less likely your phlebitis will be. And you don't want to have to start another IV on a little kiddo, especially when it's the first baby of the family and mom is having problems with postpartum depression and freaking out anyway. Telling her we have to start an IV in the baby's head will push her over the edge. You know, I'm just that was like what I dealt with my last shift. So anyway, if they're complaining about pain, if you're like, oh crap, I gotta make this IV last as long as possible, you can always make it longer. Don't ever make it shorter. Got that? Okay. All right, drugs similar to erythromycin. There's your azithromycin or your Z-Pack or your tri-pack. Has a long duration of action, so you don't have to take it. There's your tri-pack, your Z-Pack. It's really good for otitis media in children. However, just an FYI, a lot of otitis medias they're finding will resolve on their own, so they're less likely to give an antibiotic for an ear infection. Just so you know.
I'm gonna die from all these drugs we got when we were kids. Now that
Oh,
we
I got
got
a cortisol shot. I have an ear infection.
Ugh.
And antibiotics are so painful.
Yeah.
Causes less nausea. Azithromycin can be taken with or without food. Okay. Doesn't inhibit the liver metabolism. Can prolong the QT interval, which increases the risk of dysrhythmias. Not very likely, but can happen. And then we have the clarithromycins. So all the mycins are the macrolides. Azithromycin, clarithromycin, erythromycin. Clarithromycin are good for skin infections, tonsillitis, ear infections, respiratory infections, soft tissue infections. Can be given IV or PO. Obviously, with all antibiotics, can cause anaphylaxis, headache, rash, GI, tooth discoloration. So you want to be careful about this with kids. Okay, super infection, Stevens-Johnson syndrome, renal failure, all that other good stuff.
Permanent too? You're only taking it for a short time, right?
Ooh.
We'll learn about another one that does that too. Now, let's see. This is different. This ends in mycin. You have clarithromycin. This is clindamycin, but it is not a macrolide.
Oh. Why
I
did
know,
go
sorry.
a little bit like that?
I know. Sorry, guys. Sorry. It's a lancosomide.
So not a macrolide.
This is more usually used with acne. Used a lot with acne, bacteremia, all of that other stuff. Most often though with acne, you'll see that with acne a lot. Side effects, good old stuff. It's pretty much the same stuff, the same side effects. Yeah, unless I tell you otherwise, just assume it's all the same side effects. Drug interactions, there you go. Good stuff. So when they're giving multiple doses of different antibiotics, you got to be careful. Some of these you can give, so I know it says drug interactions, so some of them, if given together in an IV, are incompatible. So you want to give them at different times of the day. Does that make sense? And in different lines. They can still precipitate. It's amazing. Okay. Here we go. Here's your topical solution for acne.
Multiple slides of this drug. I'm assuming it's important.
So. Vancomycin. This guy's important. Yep. So vancomycin is a glycopeptide.
So not all mycins are macrolides.
Not all mycins are macrolide, but all macrolides are mycins. Not to confuse you.
Correlation is not
Okay, so it inhibits the cell wall synthesis. It's bactericidal, which means it kills it. Effective against MRSA. Effective against MRSA.
really emphasizing
Okay.
the MRSA. I'm gonna highlight that in red. At least 1 week.
At least 1 week. Okay. This guy's pretty popular, pretty broad. Does a lot of good stuff. Has a lot of side effects as well. Super infection's a big one with this one. Red man syndrome is when you give an IV too quickly. It will get red man syndrome. Doesn't necessarily mean they're allergic to it. It just means you gave it too fast. Okay. It can also cause severe hypotension. And then the red blotchy face, neck, chest, and extremities with the red man syndrome. So don't give it too fast, guys. Okay. This also causes ototoxicity, which is the ears. The ears. It can, and it's permanent. It can cause tinnitus, and it is permanent, irreversible damage. Okay? So if you have ototoxicity and you have ringing in the ears, you have ear damage, what else is it probably affecting? Yes, your balance and your equilibrium, right. So people who get ear problems because of vancomycin can have vertigo. Well, are they taking Vanco or are they taking aspirin? Stop them both. Okay, so did we get that? It's nephrotoxic too. So what is something as a nurse, if you're giving vancomycin to a patient, what are the things you're going to look for? Okay, labs. What? Eyes and O's. Labs are going to tell you yes, but you're going to get faster results with eyes and O's because they only check labs, what? Maybe once a day. Maybe. You can tell if somebody's has bad eyes and O's within 8 hours. Sometimes within 4, if it's during the day. Okay, so eyes and O's. That's going to be your first telltale sign of nephrotoxicity. Okay, and then your labs will back you up. So if you have a patient on Vanco and they're having low urine output, could be a problem, right? They get dizzy, could be a problem, right?
Start to see the toxicity, they'll stop giving the drug.
Right, yeah. So with this medication, it has a narrow therapeutic window. So we talked about this a little bit when we talked about therapeutic window. What do you think they're going to do for this medication? Check a peak and a trough, right? Peaks and troughs. What do peaks and troughs tell us? Yeah, right. If it's working, if we have too much or too little, we want it in this narrow therapeutic window, right? The peak is going to tell us what the peak, where the peak medication is. We take that, right? What, half hour after we give the medication? Half hour to an hour after we give the medication. And a trough is right before we give a medication. So one thing to know, especially with Vanco, there's a couple of different ones. They'll draw a trough sometimes. But especially with Vanco, if you have troughs ordered, you make sure phlebotomy has come to draw your trough before you start your next dose of medication. Okay? That's almost as important as drawing a culture before you give antibiotics, but not quite. Not quite as important, but it's important still.
Like, I think it'd be more important when it's like too much. You don't want to do that.
Oh, but if you don't know what bug you're messing with, that's probably more important, right? To know what bug you're messing with. But troughs, make sure that your troughs are drawn. Especially, they don't do peaks so much anymore. But definitely troughs. Make sure your troughs are drawn before you give the next dose of antibiotics.
Do they just find that from like blood draws, or how do they find it?
From blood draws, yeah.
Okay.
Yep. And then based on that, because they're supposed to draw them a half hour before the next dose is given, so they should get the results back. And then the pharmacist will look at the result of that trough versus the dose of the medication and either higher or lower it or have it stay the same. If it's not in the therapeutic window, they might raise the dose. If it's too much, they'll decrease it. If we're right on, they'll keep it. And then they'll talk to the doctor. Usually, especially during the day, the pharmacist will kind of take care of it, and then you give the new dose if it changes. Okay, so that's why it's important to draw a trough. If you start the medication, the trough isn't going to be effective. right? Because now you have medication in the system that's affecting the therapeutic window. Okay. Nurse enters the patient's room to find that his heart rate's 120, blood pressure is 70/50. He has red blotching of his face and neck. Vancomycin is running. Believes the patient is experiencing severe reverse effect called Redman, a severe adverse effect of Redman syndrome. What action will the nurse take?
Well, I don't know what the infusion rate is, so dropping it for that, you don't know.
Oh, you guys have it pulled up?
Yeah.
Okay, so this is, for those who don't have it pulled up and are just looking at this is a tip. This is how I kind of want you to start answering your questions. Read the question. On here, we don't have any options. So read the question. Try to answer it before you see the options.
You said that it is going too fast, so down.
Okay.
Muscle and total provider.
Okay. Reduce the infusion. Encourage the patient to drink more fluids. Report onset to the healthcare provider. Stop the infusion and call the healthcare provider. So you were saying that you would reduce it. So that's what one says, but why would one be wrong?
We don't even know it's.
But it's not, that's what I said, you don't know what the infusion rate is now, so
Exactly.
why would it be more?
Exactly. You don't know what it's running now. So really, reducing the infusion rate to 10 milligrams per minute.
Yeah.
Right. His blood pressure is pretty dang low. Right. Yep. So his blood pressure is really low. Heart rate's really high. You're definitely going to stop the infusion right away, right? Anything crazy happens, you stop whatever it is. Whether it's you're giving blood, you're giving any type of medication, you're doing some kind of procedure on a patient and they start going crazy, you stop what you're doing. Definitely call the doctor. Okay. Having the patient drink fluids isn't going to do anything. Plus, he probably feels crappy. He's not going to be drinking anything right now. Okay, patient admitted to the healthcare facility with MRSA. The nurse anticipates administration of which drug? Okay, there's only 2 drugs up there that we even talked about, right?
Yeah, I agree.
So do you think A and C are even going to be an option for, like, say you found this on the test? You can automatically count those 2 out because we didn't even talk about them, right? They're not on your list of drugs to know. You've already cut it down 50%. Now you just got to decide, is it Vanco or is it Zosyn? It's going to be Vanco. Okay. The nurse administering Vanco to a patient. Which nursing interventions are appropriate? Monitor the patient for I'll make sure it's an appropriate IV rate, right? What do you think?
Well, do you do adequate hearing? Because, hearing loss is a sign of toxicity.
That is a severe allergic reaction where the skin will start to slough off.
Yes, so weird. No, it's not fun.
Okay. Let's see what online. I'm curious. Oops. Okay. Stephanie says all. Okay, so select all that apply. Okay. So adequate hearing, we know that it causes ototoxicity, right?
Right.
And they can get vertigo, they can get tinnitus.
Oh, it is all of them. Crap. Because Stephen Johnson syndrome.
On the slide, like.
Yeah, it's an antibiotic, so antibiotics is gonna.
Okay, so A is definitely it because we want to make sure their hearing is good because if they get any ear problems, it's irreversible. It's the damage is done, doesn't come back. Appropriate IV rate? Absolutely. It can, going too fast, what does it give us? Red man syndrome, right? So we want to make sure, and it can also cause some phlebitis. So we want to make sure that we have our appropriate IV rate. What about C?
Yes, because if you have, you're like more susceptible to get seated.
Okay, and what are those called?
Hospital required.
Super infection. C. diff is a sign of a super infection. C. diff is a super infection, right? So that would also include vaginal yeast infection, oral yeast infection, thrush, right? All those other super infection stuff. Stevens-Johnson syndrome, side effect. Not a side effect, an adverse reaction. If somebody gets Stevens-Johnson syndrome with Vanco, they're probably going to be deemed allergic to it. And then what about hypotension and tachycardia? What are those signs of? But what kind of things do you see? Where is it? Right here.
But then your heart's going to go up
To compensate for the hypotension, right?
Right.
Yep. So all signs of
red man syndrome.
And then what about redness of face, neck, and chest?
Also red man syndrome.
Also red man syndrome. All of the above. Okay. Does anybody have any questions about any of those? And I'm okay. So Stevens-Johnson syndrome is a severe reaction, which in that term would be deemed probably allergic to it. Okay.
96
Whew. Antibiotics affecting bacterial protein synthesis. Woo-hoo. Tetracyclines. These are fun. These are fun ones. Okay. They are broad antimicrobial activity against gram-positive and gram-negative. Okay. Usually bacteriostatic. Inhibit the bacterial growth or multiplication. But in high concentrations can be bactericidal. Let's see. That binds to the 30S bacterial ribosome. That's just a fun fact. Effective against some species that are resistant to penicillin or other cell wall inhibitors. Drug of choice for Rocky Mountain spotted fever. Typhus, cholera, Lyme disease, peptic ulcers caused by H. pylori, and chlamydial infections. So, do we see much? Anybody need tetracycline? No judgment. No judgment.
Sometimes I just say shit without thinking, okay?
So we don't see tetracycline a whole ton. Typhus, cholera, Lyme disease, not super popular diseases, but can happen. Okay, things to know about tetracyclines. Once resistance by a bacteria develops to one tetracycline, it is resistant to all tetracyclines. Okay. Most should be taken on an empty stomach and should not be taken with milk or iron. Okay. And you want to monitor for diarrhea because they kill normal flora. They sit in the GI tract for a while and can cause C. diff. They also cause hepatotoxicity, photosensitivity. I would hate to be that guy. He looks like he's in pain. Okay. Women on oral contraceptives are more susceptible for vaginal candidiasis or vaginal yeast infection, aka contraindicated in pregnancy. Why?
Everything considered a complicated infection.
But what does it do?
Was the growth rate you decide.
And causes yellow-brown teeth discoloration. So if any of you guys, my aunt has this, but if any of you guys have older family members, because they used to give this all the time. Any of you guys have older family members with like yellow patches on their front teeth, they were probably given tetracycline as a child. I don't think so. It's pretty, and it's like their permanent teeth too. So you give it to kids, and it's affecting their permanent teeth that haven't even grown in yet. Yeah. So that's one reason why it's contraindicated in women, in pregnant women, and children under 8, because it discolors the teeth and slows the growth, which is bad too. But you're gonna see yellow-brown teeth. So, like I said, they don't do that anymore because they found out that this happens, that this is the tetracycline doing that. But older adults, if you see they have yellow and brown like blotches, it's usually like my aunt has them on her front teeth. But that's probably why they had tetracycline as children when they were kids. Okay, it's really effective it can be effective for acne. You have the same picture?
Well, it was on my slide. It was similar.
Oh, okay. Okay. Oh, here we go. Reduce the effectiveness of hormonal contraceptives. So I am guessing with this one where it says hormonal.
That's like IUD.
Yeah. Yep. With the IUDs and the stuff like that, as well as the oral contraceptives. Let's see if I have it in here. We're going to talk about doxycycline too. Okay, let's see. There's your superinfection, hepatic and renal function. A lot of the antacids, which is why I don't want to give it with milk. It has a lot of calcium, magnesium, stuff that antacids would have. Let's see. All of them say bowel function. Why? Y'all know that, or you really don't know that? Is it a lot of these say monitor bowel function?
Oh, the flora.
Yep. Because it's killing all your flora, it's causing diarrhea. Now, if somebody has diarrhea, should they stop the antibiotic?
No, isn't that a normal?
Yeah. Now, if it gets severe, that's a problem, right? And they can just take yogurt or some kind of probiotic to help that out. Okay, which statement by a patient who's received teaching on tetracycline therapy indicates that they need more teaching? I will store the medication away from light and extreme heat. I will use an additional contraceptive technique because this drug may cause the oral contraceptive to be less effective. I will take this medication with an antacid. If my stomach becomes upset when taking this medication, I will take it with non-dairy foods. C. You do want to keep it away from light and heat, so don't leave it in your car. Use an additional contraceptive. We talked about that, right? It becomes upset, take it with non-dairy foods. That's still true. If they say, I'm going to take it with an antacid, that's when you say, hold on. Dad. Drugs similar to tetracycline. Doxycycline. So, safest tetracycline for patients with impaired renal function. Okay. Normally administered PO, absorbed with or without food. Good for STIs again. Alternative to ciprofloxacin for prophylaxis of anthrax. Do you guys remember the anthrax outbreak? Yeah. Right? And all the politicians were stocking up on Cipro and doxycycline. Because who knew who was going to get hit next, right? They were mailing it through the mail, this anthrax powder. Okay, any questions about tetracyclines? Doxycycline, by the way, can be used for tuberculosis. Wait, tuberculosis? Hold on. Malaria. I lied. It's malaria. That's not on this test. It'll be on a future test. We'll revisit that.
Is minocycline included in that group too?
I believe so. Let's see. Tetracyclines, one thing to know is that the drug will break down throughout time and become toxic. So if anybody has old tetracycline in their, I was going to say closets, in their cupboards, throw it away because it will become toxic. It breaks down. Hopefully you're taking all your medication, but if somebody has extra, throw it away. Okay. The aminoglycosides. Oh, look, here we go again. Ototoxicity and nephrotoxicity. Okay, it does the same type of thing. Narrow spectrum, because they're reserved for serious systemic infections. It shouldn't be because they are. It should be, say, so they are. But administered parenterally, resistance occurs rapidly when administered as a monotherapy. What's a monotherapy? By itself. So these types of medications you'll see with a lot of different ones because we want to hit them on both sides, right? The bacteria, because they can resist one rather quickly. These types of drugs. Okay. Who's heard of gentamicin? Nobody? Okay. Thank you, Olivia.
Is that what was in the flu shots this year?
Gentamicin? Hopefully not. They were putting gentamicin in flu shots?
They were putting it in antibiotics. I think it's gentamicin. It said, are you allergic to this because it's contained inside the flu shot this year?
Really?
I'm pretty sure.
Why are they putting an antibiotic in the flu shot?
And a viral, I don't know.
Anybody else? Nobody online is chiming in about that.
Maybe one minute. Oh, she's in the flu.
I'll have to look that up because normally
I'm like 99.9% sure.
that's
Because I had to read the stupid thing, like, are you allergic to gentamicin? Because it's inside the flu shot.
Oh, it looks like it's such a small dose though.
It is, but it's inside the
Yeah.
why would
It's
they
like-
do that?
It's like 0.00003 milligrams.
So what? You feel like there's a lot of air.
As a preservative? I don't know why they would do that. That's not even enough to. That's not even like a See, like, what does this say?
Sterile.
Oh, I was hoping it had like a dose on there.
Yeah, it says like some influenza vaccines contain no antibiotics, and others contain one or more of the following. It's got like neomycin, but they're like super ridiculously small doses,
Yeah.
like 4 or 5 doses.
That's weird. I don't know. That's really interesting. I don't know why they would do that. Okay, so these
Somebody probably claimed it got them sick.
are excreted through the kidneys. And really, this one is just really gentamicin. Really the only one we're going to talk about, the aminoglycoside, gentamicin. Secreted through the kidneys, can be in our system for a very long time. And let's see. Oh yeah, some antimicrobial activity continues during this time. It's known as a post-antibiotic effect. So, because it stays in our system for so long. Okay. Black box warning. Neurotoxicity may manifest as ototoxicity, neuromuscular blockade, and respiratory paralysis. Nephrotoxicity is possible. So this is one you definitely want to monitor your patient closely. Okay. Contraindications, those who have renal impairment or pre-existing hearing loss. It can make it worse, which you could argue could also be on vancomycin. Okay, let's see. Evaluate the 8th cranial nerve function. All right, tell me what the 8th cranial nerve is and how do you test it?
Well, trochlear. Vestibulocochlear, that's what it is.
We're hearing all sorts of different.
Which is also known as the vestibulocochlear, whatever.
All crazy acoustic.
Okay, and how do you test
In
it?
this class, okay, but the vestibulocochlear is the way I remember it because it also affects balance. That's why I'm like,
I think acoustic
is that the 7th? Are we lost?
I don't know cranial nerves very well. I'm going with you guys. We're going with acoustic.
Yeah.
And how would you test it? Megan said whisper.
Yeah, you can whisper. I did my watch like when they hear the ticking.
Hey, that's pretty good. Yeah, so if they're complaining about hearing loss and they're not hearing very well, that's a problem. Okay, so evaluate your 8th cranial nerve. Assess signs for superinfection. We talked a lot about that. And then monitor your eyes and nose because nephrotoxicity is possible. Labs are good, but I'm telling you, eyes and nose are going to get you your fastest. That's where you're going to see it very first.
So it says they put the antibiotics in most vaccinations just to prevent bacterial contamination.
Oh, okay. To prevent bacterial
Just in case like somebody
contamination.
doesn't pass it.
Okay.
So these are also aminoglycosides.
Uh-huh. Yeah, but we're mostly going to focus on gentamicin. This is more of like an FYI. Neomycin for topical infections. This is where you get your polymyxin B and bacitracin. What are those? All 3 of those called? What do you find those in? The neomycin, polymyxin B, and bacitracin. Or AKA
That's what I just call it.
triple antibiotic ointment.
Ointment.
Here's your triple. You got your neomycin, you got your polymyxin, and your bacitracin. Triple antibiotic ointment. A lot of times in the hospital, you'll just see the bacitracin ointment by itself. Okay. Can be combined with hydrochlor. What's hydrocortisone? It's a steroid, corticosteroid. For minor skin irritations and bug bites. Can be used orally to sterilize the bowel. I would not suggest you do that on your own.
Just like when you knows that.
What? probably only do that under direction of a doctor. There's really no reason to sterilize the bowel in everyday life.
Yeah, it's like drinking coffee and money.
I was gonna say, don't they do coffee enemas sometimes?
Have you watched? Yeah, Straight Addiction. Yeah, I Straight Addiction. Her and her husband do like 3 coffee enemas a day.
Oh my gosh. Enemas are bad anyway.
Last semester?
Yeah.
Coffee enemas.
Oh,
Yeah, she like lays in the bathroom and butt chugs freaking coffee.
Your terminology is amazing.
I got that word from Natasha. Tell me all this cool kids.
You got butt chugs from
Yeah, she
Natasha?
said it. It was funny because you know how she
Butt
is,
chugs?
like, so you do it like 10 chugs.
Like she's training to get it out.
It's so cute. I was like, this is it.
Okay. And then there's streptomycin. You can read why it's not being used very, very often. It's a lot of things are resistant to it, and the risk for ototoxicity is higher than all the other drugs. Okay, healthcare provider orders gentamicin for patient with postoperative wound infection. Which laboratory result should prompt the nurse to consult with the prescriber about possible nephrotoxicity of this drug? Before you even look at the answers, what do you think it is? What labs are going to talk to you about your kidneys? BUN or creatinine, right? BUN or creatinine. Okay, we got our answer. Let's see where possible. Elevated serum creatinine level, decreased BUN, increased white blood cell, elevated iron. Are there any other ones? Nope. Do you guys remember the digoxin video? He talks about serum creatinine level 1.3. It's above 1.3.
Oh, kidney injury.
Kidney injury or an OPP, right? Elevated serum creatinine level. That'll tell you that we have nephrotoxicity, right? Also, an increased BUN level would, right? But that says decreased BUN level.
Which is totally, it's not that big.
So that's why number 2 is wrong. BUN is, yes, we look at that, but it's increased BUN, not decreased BUN. Got it? Doesn't do anything with white blood cells. Doesn't do anything with iron. Okay. Patient receiving gentamicin therapy, 100 milligrams intravenously at 8 o'clock, 8 a.m., 4 p.m., and midnight. At 7:30, the nurse is informed that peak and trough levels need to be drawn. When is the best time to obtain a peak level?
Well, before you give them, wait, no, just that's a trough.
Like
9 o'clock. Wait, there's other options. Would it? I don't.
Because you're gonna give it an 8.
So we need peak and trough levels. When is the best time to obtain a peak level? It doesn't work.
Stephanie says 9, so I'm going with Steph's
It's not
answer.
gonna be 1600 and it's not gonna be 20 because you do the dose and it would be the trough.
Well, 23:30 is like right before you give the next dose.
Yeah.
Yeah, so.
Megan, to answer your question about the pink bubblegum antibiotic, yes, it is most likely amoxicillin.
So good.
Okay, Stephanie's right. Peak is the highest. Trough would be before you give the dose, right?
Right.
So we're giving it at 8. So 8 o'clock, that's when we're giving the med. It's not even at its peak level because we're giving it at the same time. Same with 1600. So now we're giving it at midnight and we have a time of 23:30. That's when the trough is going to be right before we give the next dose. That's when the lowest level of the drug is, right? So the peak is going to be a half hour to an hour after the drug is given. So 9 o'clock is the best answer there. Okay. Let's see. Fluoroquinolones. This one interferes with the bacterial DNA replication. Okay. So this one would most likely be considered what? Bactericidal, bacteriostatic? Static, right? If it interferes with the DNA, they're not going to be able to replicate. It's going to definitely slow down the replication. So it's going to be bacteriostatic. Okay. Let's see. So it says under favorable conditions, many pathogenic bacteria can divide every 1 to 3 hours. That's pretty, you wait a day or two to get your culture back. That those pathogens have replicated, at least 8 times, right? For 1 day. That's a lot. Okay. So the most critical step in bacterial reproduction is duplicating the DNA. And so if we interfere with that, then they can't replicate. Okay. This is more about the DNA stuff. Yada, yada, yada. Sorry, I should have made this easier for you guys. Oh, if you need to know all this stuff. Good FYI information. Okay. Fluoroquinolones. This is your ciprofloxacin, which we talked about with anthrax, right? So, treats gram-positive and gram-negative. This is bactericidal, but I'm thinking it's bacteriostatic. Yeah. But I'll clarify that for you guys. Let's see. There's 4 generations, but we're only going to talk about maybe one of them. Active against, let's see.
So then question whether or not it's bactericidal or bacterial
Static. Yeah, I would say it's bacteriostatic, but this slide right here, bactericidal. Okay, moving on. I'll clarify that for you guys. Let's see. Okay. So on the fluoroquinolones, there have been a lot of drugs that have come on the market and then gone off the market because of concerns for adverse effects that can be pretty bad. Okay.
Book says it's static.
Yeah.
It says mechanism of action of fluoroquinolones is to interfere with the enzyme DNA.
Right.
Erase. On 364.
Yeah. See, that's why I have you guys and all your books. Just know that it interferes with DNA synthesis. That's really the takeaway here. Fluoroquinolones interfere with DNA synthesis.
I just really want monofocal.
Okay, cartilage toxicity can affect the cartilage development. Isn't this so crazy what some of these drugs can do? Okay, a lot of things that. And some of this stuff, as you've seen with drugs getting on the market for a few years and then being taken off, some of these, like a 6-month or a year study on these drugs, they don't catch these things years later. That's why they're approved by the FDA and then discontinued by the FDA. Good times. Okay. Can cause CNS toxicity. dizziness, headaches, sleep disturbances, phototoxicity. A lot of antibiotics cause photosensitivity. Phototoxicity. For all those who are wondering, fluoroquinolones are not recommended in gonorrhea. Okay.
I don't have one. Screw all of you.
Oh, you're not worried about gonorrhea, you're worried about chlamydia? Okay.
Lesser of the two. Thank you.
Levofloxacin. This is your Levaquin. Brand name Levaquin. It inhibits the DNA synthesis.
This is the brand name of
Levaquin.
fluoro.
No, Levaquin is the brand name of levofloxacin. Levofloxacin is a fluoroquinolone.
This is the brand name.
That's the generic name. Levaquin is the brand name.
Oh, this is it. Okay, never mind, I got it.
Okay.
Sorry.
It's fine. I was just waiting for the light bulb to go on. It's fine.
It's not there.
Okay.
Never there.
If here's contraindication, if you're sensitive to other quinolones, like ciprofloxacin, you'll be sensitive to all fluoroquinolones. Okay. Any questions on that? Look, monitor bowel function as well. Black box warning with levofloxacin. This is really, really important, especially for older adults, but it can happen in all ages. Tendon rupture. Yeah. So they're very careful with this stuff now with levofloxacin. So especially older adults, but it can happen especially in our older geriatric adults, this tendon rupture on the black box warning.
Is this one also the cartilage toxicity?
I think so. Yep. Cartilage toxicity. So, levofloxacin, tendinitis and tendon rupture, black box warning.
Oh.
Okay. Did you have a question, Olivia? Oh.
Oh, I already highlighted it. Okay. Oh, wait.
Oh yeah, the BBW black box warning. Yep. And then we have ciprofloxacin. Does the same type of thing with the tendinitis and the tendon rupture. So you gotta be careful with those fluoroquinolones. Yep. Right? Oh, yuck. Okay. Practice question. Which antibacterial drug has the potential to cause adverse reaction of tendinitis or tendon rupture and peripheral neuropathy? Fluoroquinolones. That's right. When your tendon ruptures, you will say the F word.
That's what I'm gonna say. I'm gonna remember that.
So, Stephanie, going with the bubble gum, if you need a mox, if you ask, they'll probably frown upon it, but if you insist, they probably will. But you'll be taking a lot of it, like half, well, like 2 tablespoons or something. But sometimes it has like a weird aftertaste. I would just take the capsule. So we've had some like teenagers that have come in that refuse to swallow any tablets. or chew anything. And so like we've given them Tylenol and ibuprofen. I kid you not, it's like a half of a cup of ibuprofen liquid. Or it's I'm just like, seriously? Just swallow this little pill.
I feel like children's Tylenol and stuff as they get older, like you get like 3 doses out of it.
Exactly, yeah. So it's a lot. It's a lot of medication if you have to take it. Just take it with the pill. Okay. Miscellaneous antibacterials, metronidazole, which is really good for gut stuff. So used in H. pylori, can be used in C. diff, can be used in diverticulitis if they're having more problems. So this I remember metronidazole as a gut drug. You'll see that a lot with if people have like ruptured appendicitis, any type of gut surgery that not usually liver itself, but more like intestinal stuff. If they've had to do like cut out some of your intestines and put it together, they'll get you on metronidazole. Now this stuff is nasty. So if you have to take it, take the tablets really, really fast because they dissolve really fast, like in your mouth, and it's nasty, nasty tasty. My son. Oh yeah. What does she swallow the BBG? Is that the bubble
I
gum?
think she thinks it's like really bubble gum.
It's bubble gum flavor.
I feel like I've had that before. My mom had those little measuring spoons that were plastic.
Yeah.
Too. And you like fill them up to a certain area, and you have to like.
Yeah, Stephanie. So it's not real bubble gum. It's just bubble gum flavored. Yeah. Sorry. Sorry, that is confusing. Yeah, bubble gum flavored.
Yeah, it's in the fridge. It's in a freaking bottle.
And they always gave you like Robitussin.
It's actually, for the record, it's actually stable outside of the fridge for 10 days. The problem is a lot of times it's prescribed for 14 days, which is why you need to keep it in the fridge. So, side note on that. So, if you do leave it out of the fridge for a couple of days, it's totally fine. Throw it back in the fridge because your length of therapy is going to be longer than the shelf life outside of the fridge. Okay. All right, let's see. What else do we need to know? Metronidazole. Okay, gut drug, metronidazole. Bacitracin, we talked about that. Usually combined with the polymyxin, which is the Neosporin or triple antibiotic ointment, right? That's usually a topical. They'll put bacitracin in people's, like, around inside of their nares if they've been positive for MRSA too. Yeah. Don't know.
They like smear bacitracin inside their nose.
They just like put the bacitracin on. Sorry, let's go back. They put the bacitracin like on a Q-tip, and then they just like put it in the nose, in the nares.
Oh, that's on here.
Did I put it on there?
No, maybe not. I thought you said you went back.
Oh yeah, because I went past the sulfonamides. Sulfonamides, traditional choice for UTIs, but there is a resistance occurring, so they gotta be careful. Okay, this inhibits the synthesis of folic acid. Okay. So us humans, we get our folic acid by eating foods, taking vitamins, all of that stuff. We don't make it endogenously. Bacteria do. So if they inhibit the synthesis of folic acid from the bacteria, it will kill them. Okay, let's see. La 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 la. What did you miss? The folic acid. So humans, we get it by food, our food sources. We don't make it endogenously, but bacteria do. So if it interferes with their folic acid making, then they die. They die. Okay. Let's see. Classified by their absorption and excretion characteristics. So classified by oral agents that are readily absorbed, some that are not absorbed, and then topical agents. Used cautiously in patients with renal impairment. They can cause crystalluria. Ouch. Who wants to pee out crystals? Do ya? We could probably make that happen.
Just give me what is it? The osmotic diuretic without See how that goes.
Okay, so remember, sulfonamides. Remember, they affect the folic acid.
Right.
Okay. Also, what is in that name?
Meth.
No, not meth.
What is happening?
Sulfa. So if you're allergic to sulfa, did you take this medication? No. No. So if you have allergies to sulfa or other sulfa drugs, you are allergic to sulfonamides. Okay? All right. Monitor bowel function. Why? Super infections. Okay. Glad we all know that. That's, yeah.
That would be awesome.
Monitor labs, right? I want high potassium. Photosynthesis, especially, this is your Septra, or Septra DS. Anybody's heard of that? That's the brand name of this trimethylpyrim sulfaminoxazole. This one is especially make you photosensitive. Okay, so any young girls or old girls taking it for UTI, they can get sunburned really fast. Okay. When teaching a patient about trimethylpyrim sulfamethoxazole, that's how they shorten it, by the way. The TMP SMZ.
I'm gonna think doesn't even look like the actual-
TMP CMZ. The nurse gives highest priority to teaching the patient to
We're on the next one. Okay.
Let's go with.
Did we talk about this? I don't think we talked about this. But it'll be a good.
Does it change their urine? I'm waiting for the answer.
You're just waiting for the answer. Okay, so it's not autotoxic. Oh, it's not even on here either. Good grief, guys. I'm failing all over the place. Who said A? Gold star for you. It is A. You're going to want to increase your fluid intake. Why?
Use cautious in patients with renal impairment.
Uh-huh.
Okay. Contraindicated patients with hyperkalemia.
Oh, that's something.
There's a good reason. Hold on. Oh,
Viking.
With may cause crystal.
Yeah.
I don't know if that's what.
I'm pretty sure it's the crystalluria. Is it? Okay, good.
The notes on those probably?
Yeah.
Like I say, I swear, I go through all this and I'm like, I'm totally gonna remember. I'm gonna remember. I'm gonna remember, and then I don't remember, and life sucks.
That's what I was saying on the one.
Okay, so increase fluid intake to prevent those crystallurias from happening.
Okay, so I'm gonna put that on.
Increase fluid intake is important with sulfonamides.
Is it to prevent crystalluria or to decrease like the effects of it?
It's just gonna dilute it.
Yeah, it's gonna dilute it, so it's gonna help prevent it. And if you get it, it will help decrease it. Okay, your patient has been prescribed this sulfonamide. Which electrolyte would the nurse monitor closely?
Potassium.
Look, calcium. Oh, look, it's one of your options. And you answered it before you saw your options, so that is probably the correct answer.
This is that because that was what we had to monitor last exam.
Well, you would have gotten it right. That's right. Okay. Patient has been prescribed sulfonamides again. The nurse realizes that this drug is most likely to treat which condition? D. D. UTI. Chlamydials or what drugs? Gonorrhea. Other drugs. Okay. We're done, my friends.
I already forgot which ones were gonorrhea.
Let's go.
Hey, whoa.
Oh, the floor.
Hold on, guys. We got a learning activity to do.
Really? I thought that was our learning activity.
No.
I think we're all just
You
trying
guys,
to-
I know you're all tired, so
Don't study for that test, like, no way.
this is gonna be an easy learning activity, but you guys got to give me a hot minute to put it in the computer so you can submit it, okay? Or you can write it on a piece of paper and hand it to me. I don't care. This is what you do. All you guys online, listen to this. I want you to write 3 things that you learned today about antibiotics. Wow, I'm not done. And then I want you to write 2 potential test questions. That's it. There you go, Steph. That's a good one. Okay. 3 things you learned. 2 potential test questions. Okay, so you guys can do it on your paper or wait till I throw it up on Canvas. Submit it for real.
She's gonna make.
I'm going to put it in real fast on Canvas. Don't forget.
I'll forget.
Don't
I
forget.
was watching the game tonight. I was like, I feel like there's something else I should be doing. Yeah, I don't. I go over Canvas religiously every single night.
Or, like I said, or those who are here can write it on a piece of paper and submit it and
No,
give it to me.
It's in my phone. It's in my fire.
So, let me what is this? Learning assignment number 8. Things I learned.
Every time, like, whatever topic comes in, I'm like, not today.
Always tested after isolation. Potential partners. You never know. Like, yeah. And I've been with Nick for 2 years, so
Speaking of that, you heard. Baby mama's calling me. Wait, are we like officially done? Other than that. What is up?
Now your test questions have to be like full test questions. So either a multiple choice with different options or a select all that apply with different options with their answers. Who knows, if they're really good, we might see a version of them on the test. I don't know. We'll see. So I said a version of them on the test. Okay, hold on. I'm almost done, guys, and putting it in the computer. 2 hot seconds. All right. Let me make sure it's published because I've done that before. Been like, it's totally on there. They're like, it's not. See, not published. Now it's published. Okay, you guys should see it.
Like highlighting in stars and then like actual highlighting. And then this is the mistake.
Brayden. Yes, it's called LA number 8, Things I Learned. And your test questions. So 3 things you learned, 2 potential test questions if you were writing the test.
Not all myosins are
Macrolides. But all macrolides are myosins.
I'm gonna start like just making.
Have any of you guys got on and done it? Mark, did you pull it up?
Not yet, I can.
I'm just about
Right there.
I'm just making sure because Shelby says she doesn't see it.
assignments.
Oh yeah, that was a thing too. Like last semester, I think.
Apparently it's under the undated assignments. Sorry.
Assignments, learning activities.
Yeah, because then they don't show up on the dashboard.
Oh,
Of, like things that are due.
okay.
I guess they're throwing off a lot of us this semester. It's not just you.
Oh, sorry.
No, it's not just you. I think we got used to it last semester. You just kind of like, oh, you just go to your dashboard and like, oh, here's all our assignments.
Yeah, it was so helpful.
And then like they're like, oh crap, there's an undated one due.
Okay. Let me make sure I covered everything I need to do.
Go pick up your SD cards from Renee's office.
Oh, you guys can pick up your med cards from my office too. Please.
Oh yeah.
Don't leave them.
If you don't, she's gonna like
If
record something on there.
you don't pick up your cards from me by the end of the year, I'll give you all a 0 and you won't graduate. How's that?
Whoa.
That's big words.
Not what I'm doing.
I don't want to be left with them.
You got my attention.
Okay, does anybody have any questions?
I have all the questions in the world for you.
Well. Well,
Listen to the fray or the script when I drive.
Minor.
What? You don't have the script?
Minor script.
yeah, we're done. We're done with lecture. We can
What else did I learn today?
You can do your learning activity now. Yes, this is the only thing we're covering on the next exam. So, know your classifications of antibiotics. Know things that I emphasized. I'll see, Shelby. No, you don't need to know which antibiotics treat gram-negative or gram-positive. As a PM nurse, you don't need to know that.
Don't we have some like brochure or something new?
Yeah.
Yes, a brochure. Make sure you're getting your brochure.
haven't. I've been too busy trying to do the stupid test.
If anybody has any questions about brochure, so I did have one question about like formatting because it's like a trifold or a bifold. Just 3 columns is great.
And Word has
Never heard of
You can do like front and back, or you can have 2, so they can print front and back. What were you saying, Amy?
Word has templates for the brochures.
Word has templates for them. Yeah. Okay. So those of you who have Word, you can have you can do a template. Make them fun and festive. Like pretend like this is going to be sitting outside of a doctor's office or something. Fantastic. Jana?
Cool.
Hey, have a good week.
Thanks. You too.
Okay.
Adios, everybody.
Bye.